doing on the time? 14:30, I'll make it. Okay, we're happy to begin.
I think
Happy?
so, yeah.
Yep.
Happy?
Good afternoon to you, ladies and gentlemen, and welcome here to the 120th annual meeting of the school. I think it's interesting that we should be meeting today here in the Merseyside Maritime Museum, given the fact that the Liverpool Tropical School of Medicine was actually founded by one of the great shipping magnates of the 19th century. So welcome here to this wonderful building, and again, thank you very much to you for coming. I'd like to open the meeting by asking the Secretary to officially read out the notice. Mr. Secretary.
Thank you. I give notice that the 120th Annual General Meeting of the Liverpool School of Tropical Medicine is declared open. Our President, Sir Richard Evans, will chair the meeting. I hope you have all signed the attendance sheet on arrival. I confirm there is no planned fire drill for this afternoon, and in the event of an alarm sounding, you will be directed to the nearest exit point. Can you please turn off your mobile phones during the meeting and presentations? Members will have been given voting cards on arrival, and I'd remind them to hold them up to show approval of the propositions being made. Thank you.
Thank you, Mr. Secretary. I'm going to take the meeting in the order of the agenda, beginning with apologies for absence. We have received formal notices from 35 members, and the apologies will be recorded by the Secretary in the minutes of the meeting, and that deals with the first item. The second item is in regard to the 119th Annual General Meeting, which was held on the 30th of November 2018. The minutes of this meeting have been circulated to all of the members, and it is my job to propose to you the adoption of these minutes, and if I could therefore have somebody who's prepared to propose adoption.
I'll propose that, Mr. Chairman.
A seconder?
Yes, Chairman.
Okay, thank you very much indeed. Thank you. Can I then ask the members now to formally vote, as the Secretary has asked, by holding up your voting cards for the approval, please? Okay, thank you. I think we can consider the minutes to be adopted. Okay, thank you. No matters of rising have been brought to our attention, and therefore the issue of the minutes are closed. I move on to item 4, which is the subject of vice presidents, and I can report that there were no appointments of vice presidents made within the year in question. Under Article 10.8.1, I have to report the retirement of Sir Michael Perry, and we're very appreciative of all Michael's efforts over a considerable period of time here with the school. Members of the Board of Trustees, it is proposed under Article 11.11.4 that the following trustees be appointed: Ms. Joanna Dodd, Professor Madise, and Mr. Andy Wright. Could I therefore call for a proposition? Thank you. Seconder? Anywhere? Okay, thank you very much indeed. Can I therefore ask the membership to vote on this matter? Approval? Thank you very much. Okay. Under Article 11.11.3, I have to report the retirement of Mr. James Ross and Jonathan Schofield, who have been phenomenal servants to the school here, and all of us owe a great vote of thanks to you. James and John, many, many thanks indeed for everything that you've done for us. Please don't forget us, and I know we're going to stay in touch, certainly with you. Thank you. We then move on to item 5.3. It's proposed that under Article 5.5, the following trustees be re-elected, Mark Allenson and Sue Russell. Again, could I put this to the meeting? Have a proposer, please. Thank you. Seconded over here on my right. Okay, and for the approval of the meeting, okay, thank you. Members of the school, under Article 10.8.1, I have to report the retirement of Sir Brian Smith. And under Article 10.3, the Board of Trustees has appointed the following new member, Ms. Nicola Bolton. Item number 7, which is the annual report. I'd like to hand over at this point to the chairman of the board, who will deliver the board's report to the membership. Thank you.
Thank you very much, Sir Richard. My report, ladies and gentlemen, for the year 2018-19 is in fact going to be a brief look back over the period of my chairmanship from 2007 until 2019. But before I do that, it's my sad task to record the deaths of no less than 4 of our vice presidents. Sir Leslie Young, who became a vice president in 1993, and represented the historic link between LSTM and the shipping industry based in Liverpool. Sir David Weatherall, Vice President since 2005 and a world-renowned hematologist. Peter Sissons, Vice President since 2013 and a noted broadcaster and advocate for LSTM. And earlier this month, Michael Oglesby, a Vice President since 2006, businessman, philanthropist, and passionate supporter of the arts and of LSTM. So would you stand just for a moment to remember them? Thank you very much. So in remembering these 4, I'd like to pay tribute to our vice presidents, of whom present today are Nicholas Baring, Jenny Borden, Dame Jane Newell, Willie Fulton, and Jesper Kierdegaard. And I'd like to say that their contributions are many and varied and largely unsung. They're always available to us with wise counsel, a wide contact network, and a preparedness to assist us in our increasingly important fundraising endeavors. So thank you all very much. So looking back over my 12 years of association with LSTM, I think we've come a long way. You will hear in a moment of our continued impressive progress in financial terms from our treasurer, John Schofield. It's not been all his own work, but I'd like to thank him on behalf of all members, trustees, and management of LSTM for the many hours, unremunerated, which he's devoted to LSTM, and particularly for his sound advice and steady hand. Thank you, John.
Thank you.
I'd like to take the opportunity also to reiterate that our continuing success in winning funding for research does not translate into fat bottom-line profits. We struggle each year to generate surpluses, having paid increasing numbers of staff and invested in buildings and equipment. Surpluses are necessary to continue to invest, particularly in people. But LSTM is not here to make profits per se, but to carry out its vital role in breaking the cycle of poor health and poverty. Now, 12 years ago, Janet Hemingway had already instilled in LSTM a sense of direction and a financial discipline to deliver its strategy. But far too much time was being spent arm wrestling with the University of Liverpool over an outdated form of relationship. Negotiations with the university and with HEFCE, now the Office for Students, ultimately led to the granting to LSTM of Higher Education Institute status. The very good news of 2019 is that relations with Liverpool University are now on a really good foundation, leading to an increasing number and depth of cooperative projects, both here in Liverpool and overseas. HEI status, in turn, led to the achievement of degree awarding powers, and it was a delight to participate late last year in LSTM's first degree ceremony, resounding drums and all. But teaching at LSTM has a long way to go for it to break out of its poor relation stance relative to research. Teaching, although it is unlikely to generate significant contributions to the financial success of LSTM, at least over the medium term, is absolutely fundamental to delivering on LSTM's strategy of saving lives. It's a vital link in the food chain of successful impact on the issues of the growing populations of resource-poor regions. The other really good news in 2019 has been the arrival of David Lelou in the position of director. The Board of Trustees chose him, and he's responded, not as a clone of Janet Hemingway, fat chance of that, but as his own man with his own style of management and his own vision for LSTM in a changing world. And you're going to hear much more about that later in the day. Sufficient for me to say is that LSTM is in good hands for the future. So I'd like to end by thanking Dick Evans for his continuing presidency and for his infectious enthusiasm which he brings to the role. I'd like to thank the members of LSTM who quietly vote at the AGM, as you've heard, seen, and have an unsung constitutional role. The trustees, who unpaid give up enormous amounts of time to keeping the governance of LSTM on track and supportive of the management. The management itself, led by David, who continue to demonstrate a world-class ability to grow not just the size of LSTM, but its impact around the world. And indeed, all those with whom I've had contact, and for making my 12 years with LSTM not just personally rewarding, but great fun. And I'll look back with great affection on a very special group of people doing important work. Thank you very much. Now let me hand over to the director, David Lelou.
Well done, Greg. Very good.
So thanks, James, and it's a real pleasure to be here at my first AGM as director. As you might imagine, it's been an exciting but challenging first year, but I am really pleased to report that LSTM continues to thrive, going from success to success. Research income has increased yet again, and in fact, we've almost reached our research income growth target in 3 years rather than 5. But maybe more importantly to most of us and most of the staff in the room, when one looks through the impact case studies that we've gathered for REF, we really are making a difference. And we really are managing to improve the health of the population we're trying to reach. And ultimately, that's the real goal of LSTM. The first few months have really been, for me, trying to focus on how we can build on the success of LSTM and establish it in a really secure place for the next 5 years.
I'm a serious...
to what is undoubtedly a very changing environment. And that environment is challenging. There is no doubt that Brexit, not only through the potential loss of European income, but in the way that it's changed people's perception of the UK, is a fundamental challenge to LSTM as a global organisation that both wants to attract people from the EU, but also wants to work with people internationally who at the moment feel that the UK is not a friendly place for foreigners. And that's something we need to address as an organisation over the next few years. The 0.7% commitment of GNI to overseas development looks like it will be secure, and all 3 major parties have signed up to that. But as James has already alluded to, funding and the highlight levels of funding are not the only thing that matters, and the overheads and the amount of money we have to invest in LSTM is a real challenge, and we will need to be very careful in how we make sure that that's secure for the future. And then also the world that we work in is changing. We see research capacity changing and research strengthening in the endemic countries where we work. We see financial flows coming through different directions through the south as well as the north. And we need to be sure that we can respond to that and make sure that we're well positioned for the future. The greatest strengths of LSTM are its staff, and I'm constantly amazed, and even, again, as director, you get a different view of the quality, the commitment of the staff that we have. And we need to make sure that within LSTM we have the best setup so that we can support those staff so they can be both productive and enjoy what they're doing. And so certainly a fair few months have been spent trying to look at the culture with LSTM, trying to address things like fixed-term contracts to make sure our staff are feeling secure, and ultimately that we can retain and attract new talent, because the future of LSTM will depend on us getting new talent into the organisation. One of the other ways that we need to think about that is in terms of the succession planning, which has been a part of our strategic plan for some time. The reality is that 5 or 10 years ago, we were dependent on a very small number of highly successful individuals. We've certainly managed to increase and broaden the number of individuals who are now making substantial contributions to the organisation. But they are all of a certain age, and we now need to invest in the younger group, in the future leaders of research for LSTM. That intrinsically has risks. It means that you are trying to guess at an earlier stage whether people are likely to be highly successful. But if we're going to change the age profile and ensure that LSTM is successful for the next 20 years, we need to do that, and that's part of a new initiative to attract new lecturers. The other thing that we need to think about a great deal, I think, is our partnership. We are essentially a public health, an academic public health institution in Liverpool. And there is a degree of paradox that we sit in Liverpool but focus a lot of our activity, the vast majority of our activity, overseas. And we'll hear a little bit later on from Bertie about the way that we can maybe learn some lessons from what we do in resource-poor settings and apply those to similar situations sometimes in Liverpool. And certainly it's very important that LSTM is a major player in the Liverpool economy. And again, we'll hear a little bit more about that later on in the professional Liverpool bit. But I think also, as I've alluded to, there is a changing environment in which we work, and we need to make sure that our partnerships with overseas organisations, institutions, and individuals are as strong as they can be for the future, because that's ultimately where we will gain the most. And we need to make sure that we really are an international organisation that happens to be based in Liverpool. And there will be a great deal of work on determining how we best do that over the next year. I'd like therefore to finish really, first of all, by thanking the staff, because their commitment and their work is really what drives the organisation. And then also to thank James. And I've talked about the dedication and commitment to staff. And although James is not a staff member, the way that he has undertaken the role of chair has absolutely embodied the ethos within LSTM. He has guided Janet and latterly me through some very difficult scenarios. He's steadied the ship when we needed to steady the ship. His expertise, his humanity, his approach to everything LSTM has done has been incredibly valuable, and we certainly would not be in this place where we are today if it had not been for James's chairmanship. So James, thank you very much indeed. It's greatly appreciated. You've made many friends here. I hope you have enjoyed your time, and thank you for your commitment.
Thank you very much.
James, David, thank you for your reports. It's now my duty to ask for the formal adoption of the annual report for the year ending 31st of July 2019, and can I therefore call for a proposal from the floor, please? Okay, thank you. And a seconder? Somewhere? Okay, thank you very much indeed. Okay. Now can I ask the membership please to vote for adoption? Thank you very much. Thank you. The reports are adopted. We now move to item 8, which is the Treasurer's report. John Schofield will present his report to us for consideration. John,
Okay.
thank you.
Good afternoon. Give you a brief overview of the financial performance of the school. I'm pleased to say that for the 11th successive year, the Liverpool School of Tropical Medicine Group is able to report a record level of income, a very impressive performance. Group income totaled £243 million, but similar to last year, this included a significant amount, 115 million, of gifts in kind, and these gifts in kind were primarily pharmaceutical drugs relating to a DFID mass drug administration program in Africa. Excluding the gifts, which is probably a more relevant benchmark, the school reported a turnover, a total income of 128 million, which represented 11% increase over the previous year, a creditable performance. As is normal, this increase in income goes directly into expenditure on research and academic activities. We had to report a deficit this year. The deficit we reported was £11.4 million, but as with prior year, this figure is impacted by some significant non-recurring items which impacted on the reported results. Most significantly, like most of the higher education institutions, we've been required to record a charge of circa £15 million in relation to pension deficit costs. Currently, we expect this figure to substantially reverse in the current financial year. It's an issue that's facing the whole of the higher education sector. But excluding this item and other non-operational accounting entries, we did record a surplus, a healthy surplus of 3.9 million, which we considered to be satisfactory. The financial condition of the group remains strong. Net assets at the year end totaled 39 million, even with provisions for pension. And excluding deferred capital grants, which is showing as a liability on the balance sheet but unlikely ever to be paid, net assets total 65 million. So the school, as I said, remains in a healthy financial position. The future, of course, is significant. We're always looking at a key performance indicator, which is the pipeline of future research contracts. And I'm pleased to report that at the year end, we had secured contracts with a total value of £272 million, which have yet to be spent. So that gives us quite good visibility for a number of years. Looking ahead to this year, we expect activity levels to continue to improve, and we expect this current year to exceed the year that we're reporting on. The estate has been a big part of the developments over the last decade, and we continue to invest in our estates to accommodate future growth plans both in the UK and overseas. And we look at options to ensure that we have the right facilities and infrastructure to deliver our services. Finally, as has been mentioned, this is my last year as Treasurer, having spent 12 years on the board. I'm happy to be passing over the reins to John O'Brien, who has many years of experience, financial experience, both in the commercial world and in the charity world. So good luck to John going forward. Thank you.
John, thank you for your reports and for the absolutely splendid work you've done for us over many years. You've made a great contribution in that area that, I mean, really is invisible to the members generally, which is the constant improvement of both financial and regulatory sort of governance. And this is in a world where accounting sort of regulations are continuously changing. John, you've done an absolutely great job. Thank you very much indeed. And therefore, it's my pleasure to recommend to the membership that we adopt the financial statements. Could I have somebody to propose, please? Thank you, Madam. And somebody? Thank you. Okay. Can we now ask the membership to please vote? Thank you. The financial statements are adopted. Okay. We now move on to item 9 of the agenda, which relates to the appointment of our independent auditors. The board, with the support of the audit committee, recommend the reappointment of Ernst & Young, and the appropriate levels of remuneration have been cleared through the audit committee to the board, and I'm happy to recommend a reappointment to you. If we could have a proposer, please. Okay, very good. Thank you very much. Well done. Anybody? It's a second? Yep. Okay, thanks. And the membership, please, to vote. Fine. Okay, the reappointment is recommended and cleared. There is, under item 10, no additional business report other than the fact I am pleased to announce well in advance the date of the AGM for next year, which will be on Thursday, the 26th of November. Having reported this to you, it is with great pleasure and thank you for your participation that I can now declare the meeting to be closed. Thank you very much indeed. Secretary, anything?
Thank you. We will take a short break to rearrange the stage to make it ready for Professor Bertie Squire and his presentation. So if you remain in your seats, or you can go for a coffee or comfort break, if the board follow Helen, wherever she is, and move through to the other room, we'll have a quick board of trustee meeting, and then we'll be back for the presentation. Thank you very much indeed.
Okay, well done, guys.
Good, thank you. Well done.
You.
Good afternoon, everybody. Good afternoon, and thank you very much for giving us the opportunity to give you, I hope, a glimpse into our world and experiences of tuberculosis care and control. I'd like to start by acknowledging a couple of the largest funding bodies for our TB work, the UK Department for International Development and the UK National Institutes for Health Research, and also the support of the Impala Consortium. The Impala Consortium is a global health research unit that consists of a large number of organizations, 11 in all, across the continent of Africa. And it's a program that is looking at addressing lung health and tuberculosis in Africa. And then I'd like to introduce my co-presenters on the stage, Fatima Kamadwala, who is a psychology student at Liverpool John Moores. And in a minute, I'll tell you a little bit about how the sequence of this afternoon will go. And Fatima will be able to tell you her story. Heather Turner, who is the TB specialist lead for the TB nursing team at the Royal Liverpool and Broad Green University Hospital, but works Merseyside and community support to TB nurses. And a bit later on, I will introduce Amina, but I'll hold that till a bit later. And then myself, so Bertie Squire. I am a clinical academic specializing in infectious diseases and tropical medicine, and I have the good fortune to be the Dean of Clinical Sciences and International Public Health at the Liverpool School, and I'm also a consultant in infectious diseases and tropical medicine at the Royal. And then, some acknowledgements which I knew I would forget if I didn't put them up front. A lot of colleagues who've helped me put this session together. Tom Wingfield, Peter McPherson, Ellie Wallace, who's helped me with the slides, Jerry Davis from the University of Liverpool, and Kevin Mortimer, and I see many of them in the audience. Thank you very much for all your help. And then under the many others, I wanted to up front thank the many patients who have given me insights into the whole issue of access to TB control, and also the many disciplines that have helped shape a lot of the work that I will just mention in the course of these next few slides. So, brace yourselves, we want to get through quite a lot. There's 20 minutes of me, 20 minutes of Fatima, and 20 minutes of you. In the 20 minutes of me, you're going to get through the burden of TB globally and nationally, and then I'm going to give you a crash course in TB transmission, in the difference between infection and disease, treatment and drug resistance. And then we're going to major on the economic and social impact of tuberculosis, touching on the World Health Organization's End TB strategy, which includes a goal to end the catastrophic costs of TB care, the first of the big disease programs to have a social goal in addition to epidemiological goals. And then I'm going to try and bring us to some regional work that we support, the Northwest TB cohort audit, then a little bit about TB in Liverpool, and then to a very personal story from Fatima. And then when we've had a bit of a chance to talk, a couple of slides just on where things are going. So the first thing to make clear is that TB incidence and mortality are both falling globally. So if you look at the top blue line, you'll see that incidence on the left and mortality on the right are both heading towards the 2020 goal. However, tuberculosis is now the leading infectious killer around the world. So it kills more people every year than HIV and malaria put together. And we're talking about 1.5 million deaths last year. The leading killer of people who have HIV infection, a huge contributor to antimicrobial resistance. And in addition to those deaths, 10 million people fell ill with tuberculosis, 5.7 million men, 3-something million women. You can tell I can't see the slides from here, but we'll do my best anyway. And 1.1 million children. And to just give that a different flavor, we're talking about 4,000 odd deaths per day. And to put that into context with something that catches the news a lot more, Ebola killed a total of 11,325 people in the years 2014 to 2016. So we're looking at a daily toll with tuberculosis. And when you think about where is it having its biggest impact, this is clearly the highest incidence in terms of numbers of per head of population. You'll see the darker green areas of that map show the highest incidence in sub-Saharan Africa, many of the countries where the School of Tropical Medicine works. If we switch now to think about tuberculosis in England, whenever I talk about tuberculosis, people say, oh, well, it's gone away. 72% of cases in the UK are among people who are born abroad, but there's been a 28% reduction in TB cases in England since 2014, and that reduction is seen both in people who are born in the UK and in people who are born abroad. And TB rates in England remain amongst the highest in Western Europe. So here we're looking at the number of cases per 100,000 population in 2017. So 9 cases per 100,000 in the UK compared to 5, for example, in the Netherlands. And you'll see for the rest of Europe fairly similar numbers, but we're up amongst the leaders, but we're still way behind the countries where we work. So for example, in Malawi, where I just came back from yesterday, 133 per 100,000 population. This is a curable disease, so curable with antibiotics. In the UK last year, 86% of those who took their medication were cured. And if you take TB treatment and complete it, it reduces the risk of developing resistance, decreases transmission, and obviously cures the disease. If we think now about the region, so TB control in England is divided up amongst TB control boards, which control large regions, which I'll come back to when we talk about Northwest TB audit. 479 cases last year. And really, the epicenter of the epidemic in the country is in London, where you see 1,691 cases last year. So now your crash course in transmission, on the left is a post-mortem lung specimen showing healthy lung. The reddish bits are healthy lung. The whitish bits are tuberculous in diseased lung. And the cavities that form around this disease lead somebody who has tuberculosis to cough out droplets. And those droplets have bacilli within them. So each of the droplet nuclei that are coughed out have the infectious bacilli in them. And they are then inhaled by a healthy lung on the right. And the droplet nuclei then get deposited right down at alveolar level and are taken up and lead to infection. That infection, if you think about a population of individuals who go through life, through the life cycle, may well get infected, but the vast majority will live with their infection for the rest of their life, so 90+% of them. So they will be infected, but with latent infection, and they'll never be infectious. A proportion of them will develop disease, so that infection progresses. The disease itself is not necessarily infectious unless it affects the lungs. And if it infects the lungs, that coughing process that I just described can lead to more infections. There is effective treatment, as we heard, with antibiotics, which, if after 2 weeks, renders a patient non-infectious, but it takes 6 months to reach full cure. So the patient has to take a large number of drugs for a full 6 months. If the treatment is ineffective, particularly if it is interrupted, it leads to the development of drug resistance. And if we develop resistance to our 2 key antibiotics, rifampicin and isoniazid, we develop something called multi-drug-resistant tuberculosis. There's still effective treatment for that, but now it takes at least 2 months for there to be an interruption of the transmission potential, and it takes 18 to 20 months to complete the antibiotic treatment. So if that's what happens up to the point of developing symptoms, we now need to think a little bit about, once you've developed symptoms, how do you get on to treatment? Now, I'm worried that the screen isn't going to show you very much, so I'm going to talk it through from the left. So symptoms need to be recognized in the health system, and once recognized, samples need to be taken. Usually it's sputum, often there's a chest x-ray, sometimes, as you'll hear maybe a bit from Fatima, a bronchoscopy, where samples are taken from the lung to make the diagnosis. Once the diagnosis is made, the result has to be conveyed back to the patient, and a patient needs to start treatment. Then they need to go through that treatment, and basically we're asking patients to jump over a number of hurdles to get to the point of a cure. Now, those hurdles each are a cost to the patient, as I'm sure you can imagine. So this is an analysis of 345 patients in rural Malawi, where we asked them about the costs incurred at each of the different steps along the way. So first of all, an informal encounter with the health service, then an encounter with the public health system, first to get the symptoms recognized, then to give the first sputum specimen, then to give a second one, then to give a third, then to get a result, then to start treatment. And each of those steps is associated with a cost, which I've shown here in dark blue, food costs, because they've had to take a day out, buy food to get the consultation, and then travel costs. And they've benchmarked them against the red column, which is their monthly income. If you can't see it from the back, their monthly income average for this population in rural Malawi is $6. So it's not a lot. But as a proportion of monthly income, you'll see that each of those patient encounters is costly, even though in the health sector there are in these facilities, no public health fees to be paid. So the first point I want to make is, imagine if we're able to get rid of a couple of these steps by a diagnostic or a diagnostic process that gives a result much more quickly. You can see that we reduce the size of the hurdles. The next thing to say is, of course, that all looks nice and linear and understandable, but patient pathways are not linear. And we know that patients, we all have lives to live, and following neatly on that sequence isn't something that is easy to do. So we lose patients along that pathway, illustrated here by the red arrows. And we know, so just watch my man, he's got a lot to do to get to the point of cure. One of the consequences of this is that if you ask patients after a single visit whether they have got through all of those steps, you'll find very few have. So these are recent data from Bangui Primary Care Clinic in urban Blantyre. 11,764 patients have been asked at exit from their visit to the clinic whether they were asked about cough, whether they gave a sputum specimen, whether they got a result from it. And basically you see from left to right in the orange, that's the whole population. You see a large number of patients don't get asked, so we're missing some opportunities. And in that single consultation, very few will get the result of their sputum specimen there and then. So we're still asking patients to come back multiple times. In the blue are patients who are known to have HIV infection, and there we see a similar cascade, although a slightly larger number do actually get asked about symptoms and provide diagnostic specimens. Now, our group at Liverpool School, along with our colleagues in Malawi, were one of the first to demonstrate this fact that I've already told you about, that patients are incurring large costs against their monthly income. And when you think about those costs in terms of monthly income, it's also important to think about the freeboard that they may have to pay for those costs. So if you take away income not spent on food, we're talking about twice the average monthly income in those days. So these are data from 2004. And that started a conversation around the world. And I won't show you all of the systematic reviews which have looked at costs, patient costs incurred in TB. There are now 3 systematic reviews. And it kicked off a discussion about this concept of catastrophic costs. So catastrophic care-seeking costs are those costs that are sufficiently large to tip a livelihood into an irretrievable poverty status. There are a number of different definitions, including 5 to 20% of a household's annual income, 10% of a household's annual income, 40% of a household's capacity to pay, more like what I was telling you about there, if you take away food costs, for example. But we weren't able to come up with a definition when we were arguing for there to be a patient cost target in the global NTB strategy, which was set up in 2015. So we did get this elimination of catastrophic costs by 2030 to be in the target, but quite where we would set the threshold for a definition of catastrophic costs wasn't an easy one. And Tom Wingfield, who works at the school, worked with colleagues in Peru and did a prospective cohort study looking at whether catastrophic costs were associated with poor TB outcomes, so whether they were associated with a reduction, for example, in treatment completion or cure. And what they did is they set a threshold and said, what happens if a household that's affected by TB has incurred more than 20% of that income? What happens in relation to outcomes? So what you see on the left-hand histogram there is that if a household has incurred more than 20%, the chances of an adverse outcome are double those of a household where they haven't incurred a catastrophic cost. So that's a population attributable fraction of 18%, odds ratio of 2. And that's not very different from the chances of an adverse outcome if the patient is affected by multi-drug-resistant tuberculosis, which I told you about before. So that work was instrumental. Tom's work and his colleague, Tom's just arrived in the audience, was instrumental in setting that global health, World Health Organization target. So how are we going to see whether we're making progress against that target? Tom and I and many others have fed into the development of a unified patient cost survey methodology, which is now being rolled out all across the world. And in 2019, these are the numbers of countries that have conducted a nationwide patient cost survey. So the green are those countries that have completed, blue are ongoing, and purple are planned. And you'll notice that the United Kingdom plans a patient cost survey. And I'm delighted to, just at this point, give another advance shout out for Fatima, because Fatima was part of the consultative group that has begun to adapt the International Patient Cost Survey questionnaire for the UK context. But what those surveys are showing is that between 35% and 83% of households do incur catastrophic costs at that 20% level. And so we've got a lot to do in getting to that goal. So, having said the UK is planning a patient cost survey, what do we know about the UK already? Well, we know, I already told you, that 84% of patients are actually completing treatment. But these are Public Health England data, which also show that patients take a long time to get from symptoms to treatment. So the top parts of those bars are patients who are taking more than 4 months to get from the onset of symptoms to the start of treatment. The middle red bars are patients who are taking between 2 and 4 months, and below that, less than 2 months. So basically, a third of patients are taking more than 4 months from the onset of symptoms to starting treatment in the UK. And it's not different across the years, and it's not different for those who are UK-born or not. So that patient pathway that I've been telling you about, it plays out in the UK with the National Health Service. And it's partly because this is a disease which you'll hear from Fatima that creeps up on people. The symptoms are insidious. And once they become more obvious, it becomes harder and harder to seek care. Now, to bring you to the region, for the past 6 years, we've been involved in promoting and conducting something called cohort audit. And this is a process that we actually have borrowed from Africa. It was piloted primarily in Tanzania back in the 80s. And every quarter, all TB patients' outcomes are reviewed to keep a track on whether we are curing. So this is now something that's been imported to the UK. In the Northwest, we've configured it on a full regional basis. And you can see across Cheshire and Merseyside, Cumbria and Lancashire, Greater Manchester, we, over the last 6 years, have seen about a total of just shy of 4,000 patients. I'm delighted to say that in the outcome indicators, we've seen an increase to more than 85% completing treatment and less than 2% being lost to follow-up. But what that big database permitted us to do was also ask a rather deeper question, which is, how well do we do in relation to indices of deprivation? Peter McPherson, my colleague who's currently working in Malawi, looked at those data from those 4,000, and in the green graph, what he's plotted are areas of residence that are ranked by deprivation. So the darker the green, the higher the deprivation index. And what you'll see on the right are the blue spots of TB cases notified, and you'll see that the TB cases notified map to the areas of deprivation. No big surprise there. But what I won't show you the results of, but I will ask you to take as read, is that when we analysed whether outcomes were, or poorer outcomes were associated with deprivation, they were not. So we're achieving the same outcomes in wealthier areas, patients who come from wealthier backgrounds, than not. Now, one of the reasons that I think this is important is something that we've piloted in the Northwest and which is now rolling out nationally is undertaking at the start of treatment. So Heather and her team undertake a standardized risk assessment to identify those patients who have complex needs. And those complex needs are often clinical, but very often social and economic. And that then gives a template for the amount of support patients need. So we have a concept called enhanced case management, ECM, and patients are graded into these 3 grades, 1, 2, and 3, 0, 1, 2, and 3. So 3 being those patients who have the greatest need for support through their treatment. What you'll see over the years of Northwest TB cohort audit is that the numbers are going down, but the proportion who need increased support is higher. So as we are controlling the disease, we're leaving it in those parts of the population where there is greatest need. Now, Tom has done a piece of work on the 4,000, on those 4,000, asking the question, do those who have the greatest need, what's happening to TB transmission in those households? So one of the things we do in TB control is when we identify a case, we go and look for any associated cases in social and household contacts. So again, Heather and her team do that. And what Tom has demonstrated is that there is a greater likelihood of finding active TB cases amongst the contacts of those index cases that need enhanced case management, and a greater number of latent infections are detected there as well. So we are seeing, even though we may be doing well in the treatment outcomes, we are seeing the fact that there is a greater potential for transmission from those that come with more complex needs. So finally, to bring this to Liverpool, we function in Liverpool on a TB clinical network, which is centred around the Royal Liverpool University Hospital. So across Cheshire and Merseyside, we see 80 to 100 cases per year, most of those in the city. But the peripheral hospitals will see less than 10 cases per year. So there's a big reason for us to function as a network in order to sustain some of the clinical expertise. We see only 1 to 2 cases of multidrug-resistant TB per year, but because we're treating for 18 to 20 months, we're discussing each week between 4 and 5 cases at any one time. So we work, as I said, in a network. We have distinct support from the Liverpool Clinical Laboratories, the Community TB Nursing Team, and Public Health England. And weekly, we discuss the TB cases that are at the top of our worry list, including our drug-resistant cases. The meetings are chaired by experienced TB consultants. At the moment, mainly Jerry Davis from the University of Liverpool, but often me, often Tom and others. There's the nursing team present. We have real-time microbiological support so that we can understand what the sensitivities are of the infecting agents in each case, make sure that our antibiotic therapy is properly configured. And we record all of our deliberations and link those to the national system. So Fatima's case was discussed at one of these multidisciplinary meetings. And I'm going to, at this point, shut up and hand over to Heather and Fatima.
So Fatima, we're just going to obviously talk about your treatment journey, but I just want you to describe how being diagnosed with TB while you were in Blackburn, starting standard treatment, coming back to university in Liverpool, how that was affected by them being contacted and being told that you had multi-drug resistant TB. How did that?
I think it started last year in summer, where I had a persistent dry cough for about 2 months. It started off with night sweats, where I had to wake up in the middle of the night, change my clothes because I was drenched in my own sweat, put the fan on so my mattress can dry up before I can go back to sleep. I went to the doctors quite often, and it took a while. I think I had a bronchoscopy to finally finalise the fact that it was TB. So I did the 2 months of standard treatment at home. I didn't go anywhere. In my third week, I was okay to go back to uni, so I was starting semester 1 at uni. And 3 days into uni, I received a phone call from Blackburn Hospital to tell me that I had to come back and just bring a few pair of clothes with me.
So you had 2 weeks of standard treatment?
Yes.
And then you were told it was multi-drug resistant?
Yeah, so in my third week, I was, I think, 3 days into uni when I received a call to say I had to come back home. So I got the train back, came home, and as soon as I went into the hospital, they gave me a mask and put me in a separate room.
So did you know at that time what multi-drug resistant TB was?
Absolutely not, no. I didn't get much information from my doctor either, so it was only until I got taken up to a negative pressure room. I Googled everything myself, really. I asked the nurses what I could, but they didn't know much because the doctor was the main.
So you started standard treatment?
Yes.
And then, because it was multi-drug resistant, you were put into isolation for 50 days?
Yeah, it was 50 days exact, yeah, that I was in isolation. I wasn't allowed to see anyone, no contact with anyone, there was no windows or, you know, I was completely on my own in the whole process.
So you were in a negative pressure
Yes.
room. How many visitors did you have during your 50 days of isolation?
Just one. My mum came to see me every day. She'd spend around £5 every day for parking though, so when we totaled that up for 50 days, it did end up being a lot of money, and we didn't know that we could, no one let us know that there was a policy where if you pay 3 times, your 4th ticket is free. We didn't find that out until very late, so there was no point. So we did end up spending a lot on tickets, really.
So your mum came to see you every day?
Yes.
And some of the things that happened whilst you were in isolation were a little bit strange. The shower wasn't working in the bathroom.
Yeah, so I didn't think of it as anything strange because I feel like because I was the one with the condition, it was as though I was blaming myself for what I was going through. So everything they did was okay to me. So it started off with, we had a little room before my room where they used to get changed into their masks. There was a big yellow bin there where my lunch used to be left every day. So they'd leave my lunch on the bin, and then once they've left the room, I can open the door and take my lunch and go. My shower didn't work very well, so my mum used to have to use a jug and wash my hair for me. They didn't want to come in.
They wouldn't fix the shower because the maintenance
Yes.
people were terrified to enter the room.
Yeah,
So for
I could
50
hear them
days,
talking,
you
yeah.
did not work in shower.
No. I didn't.
And your food was left on the bin outside your room.
Yeah, I think it was just a hassle for everyone to wear the mask, and there's only a few nurses that were actually fit tested to come in anyway. So I think it's something I was used to though. It was from the start, it was like that.
Everybody that came in had to wear a mask, a visor, an apron and gloves.
Yeah.
So it was too much hassle sometimes. So therefore people spoke to you through a glass window.
Yeah, I used to have like a tiny little window on my door where they just communicate really. Never saw my doctor at all, to be honest. I think I saw my doctor twice, my consultant. That too when I asked to see him. Otherwise, he didn't really like the idea of getting masked up.
Okay. So during this time that you were in isolation, did you come out of the room at all? Did you go anywhere within the hospital?
I didn't, apart from when I had a PICC line put in. Once I had the PICC line put in into my, they take you for an X-ray, which I was completely covered. I had gloves, a mask, a theatre outfit, and I was just dragged across the wheelchair right
So you were
down.
transported around the hospital with a mask,
Yes.
gloves, theatre gowns,
Yeah.
on a bed. So, okay, so that must have been quite frightening. What did it feel like when you left isolation?
Slightly strange because I only had a few nurses that would attend to me, and they always wore masks. So when I left the room and everyone was talking to me, I didn't really know who I was talking to because I'd never seen their faces before.
So that must be quite frightening.
Yeah.
So in terms of being diagnosed at age 20 with multi-drug resistant TB, how's this impacted on your life, Fatima?
Once I came out of isolation, I think I suffered more from anxiety and going around and talking to people. Like when I came back to uni, I struggled with crossing a specific road. For some reason, my body would just not go across that road. And I only started acknowledging that really later on, that there was something going on. I didn't like the idea of people looking at me, possibly because I was on my own for so long. Even at home, when people came to see me, I used to zone out myself. Sometimes I'd get too overwhelmed where I just want to cry. And it was hard to tell anyone because no one really around me understood what it felt like to come out of isolation.
So you came to university back in Liverpool, you transferred your treatment to Liverpool, you came into our team, and so then you underwent 3 days a week of IV therapy?
Yeah, so I had to go to the hospital 3 times a week. So I'd plan it around uni. So I'd go to uni, and then after uni I'd go to the hospital. Travel costs to that totaled up to quite a bit because I had to go 3 times a week. And when I was going through side effects, so because of the side effects, sometimes it became harder to walk to the hospital myself. So I was taking a lot of taxis, and it was very time-consuming.
How long did each visit take when you attended?
The IV was 30 minutes, and then the before and after took 10-15 minutes more.
So how long did that go on for?
8 months. Yeah, 8 months. I did the same routine for 8 months.
And during this time you continued studying?
Yeah. I did 2 semesters in 1 semester, so I completed semester 1 whilst semester 2 was ongoing. So it was quite hectic, to be honest. And it was really tiring every time I had the IV done. I was always really tired, but I had to go to uni.
And one of the things that were difficult for you was to continue your part-time job?
Yeah, when I got diagnosed, just before I got diagnosed and talks were going on about it being TB, I got dismissed from my job just because I was obviously contagious and it wasn't safe for me to be around people. So I got dismissed from that job quite early, which was hard because my parents had to basically give me money all the time to do everything I wanted to. I applied for the personal independence allowance with the working pensions, and they declined me. I went in for an interview, took all my medical records, and they score you out of 12, and I scored 0 on everything. So I felt like they didn't really know how hard it is to deal with progress.
And in terms of the university, did they offer you any support around your studying?
They do
with side effects?
They do a disability. It's so they were offering a laptop where I can record the lectures when I'm too tired, or you can talk to the laptop and it'll help you write and things. But that appointment, when I went to it, the lady that was supposed to deal with me walked out because she didn't want to treat me anymore. She was too worried I was contagious, so I didn't go through. And after that, I didn't really feel like contacted them, so I just left it.
So we advised you that there wasn't any help with costs travelling 3 times a week, so you had to go through the Department of Work and Pensions and the standard assessment form.
Yes.
And that was another difficult experience, wasn't it? Because they...
Yeah. They basically told me that what I had wasn't enough for them to be like, okay, we can give money for this.
So you got 0 points on any
Yes.
of the assessments, even though you were attending hospital visits multiple times a week and experiencing quite significant side effects and unable to work and had been sacked from your job in Clark's.
Yeah. I wasn't allowed to work anyway because I wasn't well enough. And I felt like they didn't see the severity of the condition, maybe because they weren't educated on it or whatever the reason was, but they made me feel like what I had wasn't big enough for them to help me.
And some of the issues with stigma that you faced when you were actually going for treatment were quite interesting, how you experienced those, transportation and going around the hospital, because obviously the condition is hidden.
Yeah, so I had one instance where the IV centre was upstairs on the 3rd floor, and I used to wait for the lift, and it was always a long queue at the lift. So I waited for a couple of minutes, got into the lift, and it was a busy lift, and an old man looked at me and told me I shouldn't be in the lift, that I'm quite young and I should be taking the stairs. But in that instance, I couldn't say anything because I felt like the condition that I had would scare everyone in the lift, so I had to stay quiet.
So you couldn't access the lift because no one would want to be in the lift with you if they knew you had TB, and you couldn't actually walk up the stairs because you felt too breathless.
Yeah.
So that was a tricky situation.
But I forced myself to take the stairs for a long time after that, because I didn't want to, because they can't see that I'm sick or they can't see that I have a PICC line in. I felt like my disease wasn't there and I couldn't blame them for it. I always felt like I was the one going through it, so it was my fault. They were okay to do that. It took me a while to get past that it wasn't my fault.
So in total, Fatima, how long is your treatment?
20 months. It was a year in September, and I'm due to finish my treatment in May 2020. So I've still got a while left of medication.
And during this time, you've educated yourself around drug-resistant TB, you've educated your family, the people around you, fellow students, and you've actually become quite active in support groups to try and educate people around multi-drug-resistant TB and TB.
Yeah, I feel like for me, there was no one really there apart from my nurses that I really enjoyed to see, because I couldn't talk to my friends. It was like living two lives, really. I went to uni and I wasn't sick, but then I'd come home and I'd have a box of medication that I have to take. So it was constantly battling between the two. I couldn't tell anyone because no one really knew what MDR-TB was. So, and the whole explaining to them was useless because they still wouldn't get it. So I think for me, I hope that someone can get help from me instead, because I needed that person when I'm going through it. So I'd like to be that person for someone else. And I feel like it shaped me really. I'm quite interested in MDR-TB now, and I'm basing my dissertation around it as well. So it's changed my life a lot, yeah.
So what could you teach us as healthcare staff at the NHS to deal better with multi-drug resistant TB patients? Because we're the regional centre, but we do see only a few. So is there anything that you could offer us as advice?
To be honest, I quite like the idea, like TB nurses like you, they come round and visit just to have that informal conversation with me and stuff. But I think there needs to be more education on what MDR-TB is, because it's not very common, and I feel like because it isn't, no one really knows about it. And for people like me, I feel like that's not fair, because what I'm going through, no one really gets. Because if you say someone has cancer or malaria, everyone instantly knows what it is. But when I say MDR-TB, it's kind of pushed to the side because no one really understands it. So I feel like if more people knew about it and there was more focus groups, it'd help a lot.
And you were surprised how little knowledge people do have around TB as well, weren't you? Because actually people think TB has gone away from the UK. It's not an issue. Yeah,
and because everyone's usually used to the standard 6-month treatment, when I say MDR-TB, no one really gets it. And everyone just thinks, oh, it's just, the normal 6 months. But I'm going through a long process dealing with it, yeah.
Thank you, Fatima.
You're welcome.
So thank you for that, and I'm sure you'll appreciate the bravery that it took for Fatima to take us through that story. So I wanted to, just before throwing this open for everybody, just to remind you what I said earlier about multi-drug resistant tuberculosis taking 18 to 20 months. So you've heard that from Fatima. You'll have heard her mention PICC line, so she's had to have an intravenous line for her to have her antibiotics 3 times a week. And she's had to have that for a total of 8 months. So it's 8 months of intravenous therapy that she had to complete. And before I go any further, I wonder if I could ask Amina, who is one of our TB nurses, to just ask a few more questions or any comments from you.
Yeah, firstly, I'd like to say, Fatima, you're doing amazing. I know it's a long journey and you're doing really well, but... I
think Amina's got a mic already.
I've got one on, yeah. Do you mind just telling everyone about the side effects that you experienced from the medication, because they were a lot? So from the beginning to kind of now.
Yeah, I think the first side effect was the second day I started treatment, where my tongue started to peel. And because it started to peel, I started to struggle to eat. Anything I ate was very bland or just boiled, because everything else was either too spicy for me. And that carried on for another 9 to 10 months, where I just had to suffer when I was eating, really. And then it slowly went on to my skin started to get darker and more dry. I started to lose a lot of hair, which was really difficult for me. A big one was I suffer from peripheral neuropathy because of one of the side effects to one of the tablets called linezolid. And that was a very painful process, because I struggled to walk, I struggled to do anything. Eventually, I had to stop the medication that I was on and take more painkillers. So that probably was the biggest one, yeah.
So there was a lot of pills?
Yeah.
On
Oh, yeah, I had a lot of, apart from the course tablets, I had a lot of tablets to help with the side effects as well, so it's a lot.
So at this point, I'm quite intrigued to know whether you're prepared to show people your fancy water bottle, Amina.
Oh, it's in the room outside.
Oh, it's outside.
Oh,
okay. So Amina's taught us something that, of course, when you're having to take that many medicines a day, and you're a student, there's a whole business of taking out your pills. And Amina found a water bottle that has a dosette box along the side. You can open each one for each day. It's a cool, maybe in networking you could show some people, because it's something that we're thinking we'll try and roll out for the TB
for other patients
more generally. But I just wanted to say a couple of things about what Fatima was saying about side effects. So she mentioned skin darkening. So one of the drugs she's been on is called clofazimine, and this does lead to the deposition of a dye in the skin. And the other one is linezolid, and she made it sound like it was, she had a neuropathy. But neuropathy means that you've got a constant burning sensation in the nerves in your feet, and unrelenting, so day and night. And that meant that she also had to have some painkillers, gabapentin and a number of others, which are very sedative. So throughout that time, she's managed to carry on with her studies. So these side effects are an indication of the difficulty we have with second-line treatment. So second-line treatment is not only longer, which I'd already told you about, but also has a much higher drug side effect profile. Thankfully, one of the things that has happened in the last year is that we've demonstrated, we at the Tropical School in conjunction with many other centres, that we can reduce the TB treatment duration down from 20 months to 9 months and get the same outputs. And we now have a number of new drugs which don't have those side effect profiles. But Fatima needs to continue and complete her treatment. And thankfully, since stopping the linezolid, her neuropathy is, I think, a bit better, but it's still left you with some difficulty. Mina, did you want to raise anything else?
Just how good and persistent you've been, and positive as well with continuing with your uni work while taking the medication. And again, talking about side effects, you were very, very tired. And you still are, to be honest, but you persevered and then you're doing amazing.
Thank you. So, opportunity for anyone who wants to ask any questions of any of us. And would you mind just a quick introduction, just so that we know?
Professor Lstm, I'm from the Lstm. In 1980s, I was responsible for a district of Mahalapi in Botswana for TB program, and we did it very well. But HIV came in and it went up again. But I see from your map, Botswana is doing better than other African countries. Can you tell me that some countries are doing better? Why so? Because we see that people are not doing well, but can you tell me some countries are doing well? What is the reason for that?
I think there are multiple reasons. Certainly for Botswana, as your example, and many other sub-Saharan African countries that were very badly affected by the HIV pandemic, the advent of public health approaches to antiretroviral therapy have meant that the proportion of patients who get infected with TB and who progress to disease has gone down, and we're basically seeing some control in terms of mortality in that way. But there are a whole series of other reasons behind that. So some countries have stronger health systems. Some countries have had stronger investments in TB control generally. And you will understand that when you have some countries that have very disrupted health systems, particularly those that are affected by either natural or political calamities, you can see how sustaining a system whereby you can diagnose, as I've just described. This is not something that you diagnose on a finger prick. You're going to need to get... I have this argument with my colleagues that of the big killer diseases, the one that is still most dependent on a functional health system is tuberculosis. We don't have a finger prick test for diagnosis. We don't have a 3 or 4 day course of treatment. We don't have a vaccine. So those three things make it really tough to control. And so in large measure, TB control is dependent on a functional health system so that you can make sure you have diagnostics coming in, make sure you have treatment. I saw another hand over there.
Hi, so Emily Adams, Lstm. Fatima, I want to thank you so much for coming along and sharing your very moving story. Congratulations and welcome to our community. I hope we can help you further. What I was really disappointed was to hear the reaction from the university and the very poor support that you've received, and you've sort of disconnected from them. Is there anything we can do about that for you, but more broadly for other patients, education, their university or their workplace? I mean, how can we address that?
Fatima, any thoughts?
I feel like when I got diagnosed, everyone in the university found out straight away because they go through the screening process, and everyone realised it was me that was the TB patient. And I feel like if that was done more anonymously, I wouldn't have felt as strange coming back to uni, because it was something I couldn't hide anymore. It was out there to everyone. I think financially there should be a lot more help for TB patients, because I feel like that's probably the biggest downfall you go through. Even before you get diagnosed, I got dismissed from my job before I even got diagnosed with TB. So I was jobless from then, and then going through the whole process up to now, even a year in, I struggle to get into a job, but I still don't get any financial help. Like we said, I applied for the personal independence allowance and got rejected completely. So I'm having to take different routes to get through to them, and it is difficult. I think financially is probably the hardest factor that I've had to go through.
Emily, I think you raise a very good point for us to think hard about how we support both students and patients. One of the challenges we have with tuberculosis, particularly, as you heard, a lot of the experience around isolation was actually not here in Liverpool, and it was in a centre where there isn't so much familiarity. And I think one of the difficult things we have in our hub and spoke network is trying to make the decision about should we be supporting treatment in the peripheral hospitals or should we be bringing patients to our own facility. But there are pros and cons with both approaches. There's the pro of them being able, in an environment where this is a much more familiar disease, but there's the con of taking people away from their families. And it's a tension that we face quite a bit. And then there's the whole issue of how do we sustain confidentiality around an infectious disease, but also carry out decent contact tracing to make sure that we find any other cases, treat them early as possible. So it's a tough one, but in amongst all of that, I think what comes out for me with Fatima's story is how much it resonates wherever we look at tuberculosis. There is a cost to every one of those visits. There is a cost, not just in terms of parking fees for her mum, but there's a cost in terms of the days lost going for your IVs, waiting in the lift, etc. And I think we need to recognize that. Sorry, I'm talking more than I was intended. I saw another hand, I'm sure. One there and then one over here. Should we go? Sally, I think there's...
Hi, I'm Sally Thurbold. I'm a professor in social science and international health at Lstm, and a lot of the work that we do in social science is understanding patients' experiences. And I just want to thank you, Fatima, an incredibly brave, resilient testimony. It's really wonderful that you shared that, and the recommendations that you've made and the dialogue that's just been happening are so important to understand the multiple costs and the multiple different experiences that you've been through. So I was really moved by your story, and it's very brave to share it. Thank you so much.
Bertie, is TB a failure of childhood BCG vaccinations?
This is a question we get asked a lot. So many people are familiar with BCG vaccination. It's the oldest vaccine in the world. Probably more doses of that vaccine has been given than any other. It's a live vaccine. It's been around for a very long time, but it's never been effective at preventing adult tuberculosis. So let me rephrase that. It has a maximum of about 70% protection if you get your BCG vaccination in childhood at preventing adult pulmonary tuberculosis. And that 70% functions most in the northern climes. for reasons which we can discuss, immunological and otherwise, protection that is given by BCG within the tropics seems to be much less. So basically, BCG continues to be given to prevent the childhood forms of tuberculosis, so the disseminated miliary tuberculosis and that sort of thing. But it's not a failure of the vaccine program as such, it's a failure of the vaccine to prevent adult disease.
And can I follow that up, please, and ask why Japan, if I read your slide right, has such a high rate of infection?
I don't think it is Japan.
Was it not Japan?
No, I would need to have a look at the map.
In which case that would answer my question,
yeah,
sorry.
No. Having said that, Japan did have phenomenally high rates of tuberculosis until relatively recently. So 60s and 70s, the rates of TB were really high. And that's one of the reasons why the Japanese Anti-TB Association has been really a big global player. They've rolled out a lot of training. A previous member of the royal family, Princess Chichibu, gives a prize at the International Union against TB and lung disease because the imperial family were affected by TB. So Japan did have a lot of tuberculosis in relatively recent memory. Some more questions coming up here.
Thank you very much, Bertie. Thank you very much, Fatima. My name is David. I'll be talking later today. So I used to work for WHO, and one of the things that I'm interested in is this figure of 500,000 MDR-TB cases are reported each year. Most of them are in Brazil, South Africa, Russia. And I'm just going to ask you, based on what you said at the beginning about the catastrophic cost of illness, the work you've been doing in Malawi, what are the prospects for people with MDR-TB in some of the countries where it is greatest in terms of incidence, given the enormous impact it has, not just on the person's life, but I'm just thinking of your mum, Fatima, coming to see you so often. It must have had a huge impact on her life as well. It seems to me this is almost an impossibly difficult issue to deal with, and that we might be having to recognize that MDR-TB is going to be with us for quite a long time to come.
So you raise a very important point. I think I would answer it in two parts. There's definitely the issue of managing those who do have MDR-TB, and I do think that there are hopeful things on the horizon. So we already have drugs. We've moved in the course of the last 2 years from the 18 to 20-month regimen to a 9-month regimen to the prospect of an all-oral regimen. Personally, I have some concerns about moving too quickly in that area without us yet having randomized controlled trial evidence around all of that. But there is definitely the prospect of newer drugs coming online, and if used well, I think they can make a lot of difference to those who have MDR-TB. I think the bigger question for me is how do we turn off the MDR pipeline? Because one of the things that we really have to do at the same time, and at the moment, there is a big danger that there's a lot of attention given to the management, the diagnosis and management of MDR-TB, rightly so, but we need to be sure that it doesn't detract from the things that I was mentioning before, functional health systems that make for decent diagnosis and decent management of first-line drug-sensitive TB, and decent giving the right doses, making sure that people don't actually develop drug resistance. But you're right, we're already seeing that even with drug-sensitive tuberculosis, in some countries, 70–80% of families are incurring catastrophic costs. So that means that disease has pushed them beyond kind of sustainable livelihood mechanisms. And in MDR-TB, we're seeing much more. So it is a big issue. And I will shortly just round off with a couple of slides with some thoughts about how we might mitigate some of that. I did see another question here.
I'm John Williams. I'm a volunteer with the Lstm. And 10 years ago in Cambodia, I was struck by the difficulties of treating TB. And you've demonstrated very graphically the difficulty that you have, even if you're an ultra rosetted, compliant patient, as Fatima's demonstrated. But one of the difficulties is compliance, which compounds the difficulties that you've described. And the trouble is that people with TB don't feel particularly ill in the early stages when it's most effectively treated. And so we developed this system called DOTS, which is a directly observed therapy system. Is that possible in a malfunctioning health system?
You've raised lots of questions. So you're right. Making sure that patients are supported to complete all of their treatment is a really important part of what TB control is about. There is a big debate about whether directly observed therapy is the best way to make that happen. And in fact, Paul Garner and colleagues have done systematic reviews at the Liverpool School which have really shone a light on the deficiencies around directly observed therapy. You can imagine that if you insist that a patient makes a journey every day to a health facility to have their drugs swallowing supervised, we're going to incur more costs for them. So I think there's a lot to be done about how does one support, and I don't think it's all about directly observed therapy. There's a lot more around support. In the question you raised about symptoms, you're absolutely right. This is a disease that creeps up, but it is also about making sure that health systems are responsive to those symptoms as they emerge. I'm going to take one more, and then I'm going to say that we've done our time. But if there isn't another one, thank you for engaging very much. It's been a pleasure. I hope you've had a bit of a sense of our world, as I hoped. In case you thought this was all new, it isn't. Robert Tressel wrote The Ragged-Trousered Philanthropist back in 1910, actually. He wrote it in 1910. It wasn't published till 1912, after he died. And he died of tuberculosis, having worked in different parts. He's born in the city, died in the city, but worked in South Africa for many years as well. And he wrote, "Those who profess to be desirous of preventing and curing consumption, tuberculosis, must be either hypocrites or fools, for they ridicule the suggestion that it is necessary first to cure and prevent the poverty in which people live." Now, I personally think that it isn't a question of one or the other, or curing one before the other. And I think what I want to leave you with is the idea that we can make a big difference on the left of this slide by reducing the costs, by the way we arrange our services, by being more sensitive to the needs of our patients. So making sure we're not asking for them to make unnecessary visits during a diagnostic process, making sure that we are giving them the most streamlined pathway through the health system that we possibly can, supported by the development and deployment rapidly of better diagnostics, shorter regimens, and treatment access. Thinking hard about ambulatory care. One of the great things that you heard is that actually when Fatima first started her TB treatment, she was on the 6-month regimen, which most people can start as outpatients, supported, and they don't need to be admitted to hospital, and very often can continue with their normal lives. But we're only going to make so much progress on the health system side, and I do think there's a lot of work to be done on the other side, which is to compensate for some of the remaining costs through things like universal health coverage, patient support, the kind of thing that Fatima was advocating for. And even in a country like the UK, where we have an NHS that provides care and diagnosis free of charge for any of those things, we do need to recognise that costs are incurred in a whole series of other ways, including car park charges and the like. So I'm going to leave you with that slide and say thank you very much indeed. A duty, sorry, and I've forgotten. Helen, forgive me. There's a short break, 15 minutes. Please do feel free to stretch your legs, but could you be back and seated for our director, David Lalou, to be interviewed by health by Professional Liverpool about future directions. Thank you very much.
Sam Airy.
Ladies and gentlemen, good afternoon. I was told when I arrived there would be some noise in the room, and I should just wait for it to settle down. But I'm pleased to see you're all very well disciplined. I'm Philip Rooney. I'm the chair of Professional Liverpool. That's the membership organisation for professional and business services in the Liverpool City region, and I'm pleased to welcome you to our Region of the Future event this afternoon. Before I introduce today's event, I'd just like to thank the School of Tropical Medicine on behalf of Professional Liverpool for allowing us to participate in the Future Focus Day today. It's a real privilege for us to do so. And a special thanks to Professor David Lalou, the director of the school, for agreeing to participate in the Q&A session, which is about to unfold. So to that session this afternoon, Professional Liverpool's Region of the Future series connects our members with the people, the projects and the ideas that will make a difference to the economic and social well-being of the city region in the years to come. It also enables us to showcase the innovative, groundbreaking work, forward-thinking and social improvement which is exported from Liverpool around the world for the good of others less fortunate than we are. And so today we are delighted to be able to put the spotlight on one of Liverpool's great success stories and, if I may say so, one of its slightly hidden gems, the School of Tropical Medicine, whose global impact for nearly 125 years is immense. And we're going to do that through a conversation between Professor Lalou and my colleague Paul Furlong, who chairs Professional Liverpool's Creative, Digital and Technology Sector Group. And so I hope you enjoy what you're about to hear. And without more ado, I'm going to ask Paul to come to the stage to introduce Professor Lalou properly. Thank you very much.
Good afternoon. I'd like to introduce to you David Lalou. He is Professor of Tropical Medicine, and as most of you know, he is the Director of the Liverpool School of Tropical Medicine. He also holds an honorary consultant position at the Royal Liverpool University Hospital. He trained in general medicine, infectious diseases, and tropical medicine, spending 3 years in Papua New Guinea and undertaking clinical and laboratory research in Oxford before moving to the Liverpool School of Tropical Medicine in 1999. His main research interests are in epidemiological studies and clinical trials in research-poor settings, particularly in HIV-related infections, malaria, and envenoming. He currently has collaborations and studies in a number of countries, including Malawi, Sri Lanka, Uganda, South Africa, Kenya, Eswatini, Nigeria, and Vietnam. He has a strong interest in guiding the careers of young UK and African scientists and supporting African research capacity strengthening. He chairs the NIHR Global Health Research Independent Scientific Advisory Group and is a member of the MRC Global Health Group. David grew up in the Midlands and studied at Newcastle University. Medicine runs in his family. His father was a GP, 2 of his sisters are doctors, and both of his children are doctors as well. David loves sport. Before his knee gave out, he was a keen triathlete, and he still enjoys swimming and cycling. He loves watching rugby and cooking Southeast Asian cuisine. So would you please join me in welcoming David to the stage? So David, welcome.
Thank you.
Thanks for joining us today. So I'd like to start this afternoon's proceedings by asking you some questions, and then we'll open up to the floor to see if anyone else has some questions off the back of what we've talked about. Before we go any further, though, I've just mentioned in the introduction that you're a big fan of rugby.
Yeah.
How do you get by in such a football-centric town as Liverpool?
Well, it's actually a real problem. So when I first arrived, almost, in fact, just 20 years ago, my first weekend here, it was, in fact, the semi-finals of the Rugby World Cup. and a friend came up from Oxford, where I'd been previously, and we went around the entire town trying to find a pub showing a rugby. We could find Norwegian football. We could find any other sport apart from rugby. And I nearly turned around and went home, back to Oxford at that point. I'm very glad I didn't, but it was an introduction to Liverpool, the football mad city, essentially.
Brilliant. So let's start with you explaining to us your route into tropical medicine.
So I think, like many of the people in the room who are interested in tropical medicine, I've always been fascinated by different cultures, different approaches, and that was something that I think I was aware of as a child. I went to medical school in Newcastle, worked there, worked in London, and was very interested in infection and interested in the tropics. And then I went to a Royal College of Physicians lecture, and in fact, a professor of tropical medicine at Oxford was giving a talk. And at the end of the talk, I went down to talk to him and just ask him a bit of advice. And I remember vividly, there were 2 or 3 people ahead of me and thinking, is it worth it? Should I just go to the pub? And luckily, I didn't go to the pub because I talked to him, and 4 weeks later, I had a job offer in Papua New Guinea. And that started me on a career I think that otherwise I may not have taken. I think it's, you talk to young scientists and young doctors, and they say, how do I get to this place and this career? And the reality is that most people, and most people around the room, have got to where they are almost by accident. And it's taking opportunities when they come up, and it's just a bit of luck.
And so I mentioned as well in your introduction that you're a big fan of Southeast Asian cuisine particularly, but you've done a lot of traveling, so does that influence the cooking as well that you do? Papua New Guinea and other places that you've been around the world?
Well, you certainly wouldn't want Papua New Guinean cuisine.
Okay.
It's the most uninteresting cuisine in the world. But yes, I think again, and reflects again. I think that many of us are just interested in different cultures, different approaches, different cuisines, and that's part of what we all do.
Brilliant. So can you give me a brief history of the Liverpool School of Tropical Medicine and explain why, out of all of the cities in the UK that it could have been established in, why Liverpool was the city that was chosen?
Well, it couldn't be more appropriate, actually, as sitting here in the Maritime Museum, because, of course, we are here, essentially, because Liverpool is a seafaring city. And I think we forget that at the end of the 19th century, there was something like 8 or 9 steamships. Elder Dempster was sending off steamships to Africa, 8 or 9 steamships every month. So there's enormous interplay, particularly with Africa at that time. And they were getting goods, palm oil, bringing it back to Liverpool. Those steamships were, in fact, increasingly staffed by Africans, because as you moved from sail to steam, you didn't need some of the expertise that you need on sailing ships. And there was a perception at that point that Africans were more appropriate and more used to actually working in hot conditions that you'd seen under decks in a steamship. And so you had this increasing number of Africans in the kind of amongst the sailors, and an increasing attrition of the sailing staff and also some of the workers overseas from tropical diseases. For example, in 1892, all of the staff of one of the ships died from yellow fever. And so essentially this was seen as a problem both in terms of economic terms. There was also concern about the importation of cholera and other tropical diseases into Liverpool. And so Arthur Lewis-Jones, who was a prominent ship owner, then in 1898 suggested that they should found a tropical diseases hospital at the Southern Hospital at that point. And it started from there.
And obviously that was back in 1892. The world has moved on quite considerably since then. How have you seen that the school has adapted to the changing world in that time?
Well, so I think it's in some ways we've adapted, in some ways we've continued. So one of the individuals that was very influential on Alfred Lewis-Jones was somebody whose name I've now gone completely. One of the first female explorers, Mary Kingsley, who was one of the most prominent female explorers in the very late 19th century. And she really was remarkable because she went out to Africa on her own at a time when women didn't travel. But maybe more importantly, and she's written 2 books which are actually incredibly accessible now, They really are quite entertaining. One called Travels in West Africa of 1897. I would actually urge people to really look at it because it's a fun read. But she was very remarkable. The first woman to talk to Liverpool Chamber of Commerce. But she had a very different approach to what was a very colonial approach at that point. She felt that Africans should be governed by Africans. She was very critical of the missionary zeal to convert everyone. And I think some of her influences and some of her approaches really did actually rub off on the founders of LSTM. And I think certainly that ethos, I hope, is still with us, that we work in partnership with people, organizations, groups in Africa and Asia where we work. And that bit stayed. I think what has changed, of course, is science. The first few years of the school were about sending off expeditions to study, to bring things back and understand what was going on. We set up our own laboratories in various parts of the tropics. And I think what's changed now is the way that we do that. This is now all done in partnership. We work with lots of our staff overseas. We have major centres where there are substantial investments. And so we've gone from this kind of again, a colonial attitude of going out there doing and bringing stuff back to really working on the ground. And it's only by working on the ground that you can solve many of these problems.
And you've mentioned quite a few times already that as a school you work very heavily in Africa. And you've kind of touched on why that is. But can you expand on that a little bit? Why is it the case that a lot of the work done throughout history and now is done in Africa?
So there clearly is a historical connection, but the reality is that most of us are most interested in the populations at the greatest need and the poorest populations, and the largest number of countries who meet those criteria are in Africa. I mean, it doesn't mean we work a lot in Asia as well. For example, STM was involved in setting up the Faculty of Tropical Medicine in Mahidol in Bangkok, and that's a connection that's been going for 40, 50 years and is continuing to this day. So it's not exclusively Africa, but I think fundamentally the problems that we're most interested in and we have the expertise in addressing are certainly in a much higher proportion of African countries than elsewhere in the world.
And there's a line on the LSTM website that says breaking the cycle of poor health and poverty since 1898. Can you tell us how LSTM projects contribute to alleviating poverty and maybe give us a few examples of some of those projects?
Well, I don't think you can have a better example than what we've just heard. And the catastrophic costs that were demonstrated in TB that affect, again, not just very, very poor populations, but even populations in the UK, I think is a really good example of that interplay between poverty, poor economic growth and health. And there's been debates for many years, and Jeffrey Sachs was one of the first people to actually talk about how this incredibly interlinked relationship between poverty, economic growth, and health is just something that is there. And he advocated that you should invest in health to actually drive economic growth. Controversial to a certain extent, but you can't separate the two. And I think what we deal with in many scenarios are the issues about how poor people access care, how they get to care, and I think if you can help improve their access, then you can actually, to a certain extent, alleviate some of that poverty.
So we've talked about the global reach that LSTM has. How can an institution with such global reach be relevant to local and regional issues that we would have in the Liverpool region and the Liverpool City region?
So I think, first of all, it is important to reflect, LSTM will always be a place that focuses predominantly on resource-poor settings overseas. That's where our expertise is. But equally, I think it's really important to recognise we are a public health institution. We are sitting in Liverpool, a city with some of the worst health outcomes in the country. And it's really important that we think, as an organisation, what it is we can do to help deal with some of those problems. Again, we'll go back to Bertie's TB challenge. I think that's a good example of how you can use lessons from the global south and that are very applicable to some of the concerns we have in the UK. And there are other examples. The one that strikes me at the moment particularly is that we're talking a lot about, in the UK, about the challenges of poor rates of vaccination and the measles epidemics, etc. Now, some of that, of course, is due to a rabid group of people who don't believe in vaccines. But we have learned endlessly from lots of work on vaccine uptake in Africa and Asia that access to the vaccines is the critical thing. And if you start to look at some of the access that, again, poor populations in the UK have to vaccines, can you get your child vaccinated in the evening, or do you have to take up a half day off work to get your child vaccinated? There are barriers to vaccine uptake, particularly if you've not got a great deal of resources. The work we do on understanding the behaviour and those kind of issues in Africa, I think, are as relevant to many populations in the UK as they are to where we've learnt those lessons, and of course vice versa.
Can you give me any other examples of what you've learned overseas that are applicable in the UK?
So I think the list is endless. I think that if I was to focus on one thing, I think it's well, there's two things I'd talk about. One, I think, is the importance of integration of services. And it may have been more stark in resource poor settings initially, because the way that donors have essentially funded programs has been traditionally very vertical. An HIV program, a TB program, a malaria program. We learned very early on the importance of integrating TB and HIV programs because the two are completely inextricably linked. And I think we can apply those same lessons here, that actually you need to have joined up health services. You need to have joined up health and social care services. And our biggest problem in the UK at the moment is not joining up those two services. But joined up services lead to better outcomes. And I think that, for me, is one of the, I think, the major learnings that one can't come across. And then I think the importance of understanding the population's beliefs, the population's challenges, the social science that goes behind just biomedical interventions. If you don't understand that, then you're not going to achieve the health outcomes you need to do. And there was a really good example, I think, maybe from the Ebola epidemic, where people were getting frustrated because you were not achieving, the West African Ebola epidemic, although same applies to the DRC now, but people were not achieving what they wanted to do, and that was predominantly because they weren't actually investing in understanding the issues that were facing the population, who were frightened of coming to a health centre because they felt they would automatically die. The same things apply here. You've got to understand what the population, what the patients, even actually what the health personnel feel and think, if you're really going to have a good health system.
And what are your thoughts on any unique challenges in the Liverpool health economy with tropical disease diagnostics and management based on an increasingly diverse population?
So I'd start with actually our health outcomes are really poor in Liverpool, and we have to face that, and we have to think how we can adjust those. The public health messages that we need to think around smoking, around alcohol, are really key because they underpin everything. And I think in that is infection and the whole concept, I think, of increasingly recognised of multimorbidity. This idea that very few people, certainly very few people as they get older, suffer from one disease, they suffer from multiple diseases. And an infection will play a big part in that. But again, in a resource-poor setting, we're used to dealing with multimorbidity, with multiple diseases that interact. And I think those are things that we can read across. Many of us in the room will work in infectious diseases in the Royal. Antimicrobial resistance, for example, is not just a resource-poor setting problem, it's a global problem. And dealing with those kind of issues and understanding how we best manage those, I think, is a really important part. Tropical medicine in Liverpool itself is always going to be small beer, but we do have populations in who our expertise is needed, particularly recent immigrant populations, asylum seekers, and that's a very important area of the work that we do. But ultimately, I think it's the general approach that's more important than any specific infectious disease knowledge that's going to make a difference in Liverpool.
We've talked about how LSTM supports the city and the city region. What do you think what do you feel the city region does to support LSTM?
I think from the city perspective, one of the greatest things is that it clearly has decided that the life sciences, and within life sciences, infection is one of the things on which we're going to major. And so I think for us, it's really exciting being a city that really wants to support the kind of activities we undertake in partnership with the University of Liverpool in particular, as a place that we can go out and sell both nationally and internationally. Liverpool is a centre of excellence in infection, and being in this city is really, I think, really helpful in doing that. We've just developing a new joint centre called the Centre for Excellence in Infectious Disease Research. We're developing that from what's been a very small, certainly a kind of grouping that was just aimed at just engaging with commercial activities, to a much broader centre, which will really hopefully put Liverpool on the map. And the availability around the city of SMEs, of funding to support SMEs, of city funding to support initiatives such as we see in Paddington development, is really important, because we, as LSTM, can be at the heart of that, supported fully by the civic authorities.
And so you've touched on it a little bit there, but how particularly is the school linked to the business and the knowledge quarters?
I think it's at the heart of what Liverpool's trying to do at the moment. Again, we've just gone over the focus on life sciences, but it's us engaging with the business and the knowledge quarter. It's also, as we expand, we drive more jobs, we develop the estates, which all, I think, come together to make Liverpool a more attractive place. And the reality, we have to be realistic. Liverpool suffers from its reputation outside the northwest, outside Liverpool. And anything we can do as a city that talks about the excellence that we have, that talks about what a great place it is to be, to live and work, is something that I think will help the city develop as well. And I think that's part of the engagement with the knowledge quarter and the business community.
So looking to the future, what pioneering research is the school focused on at the moment?
That's one of those questions that's impossible to answer, and of course, always are going to offend somebody in the room because I've not mentioned their proof. I mean, there are lots and lots of examples, and I think one of our strengths is that we do really undertake work that's absolutely focused on an intervention, a treatment, a vaccine, something that will make a difference. So we don't do a lot of blue skies thinking, of just purely curiosity-driven research, and we will never get a Nobel Prize out of LSTM, and nor should we, because that's not really what we're focusing on. What we have is some really excellent research on developing new interventions in terms of drugs for filariasis, drugs for TB and malaria. We are absolutely world-leading in our understanding of insecticide resistance, and through the IVC, the development and pushing out of new projects. But I would extend that, it sounds slightly less sexy, but I would extend that to the work we do in implementation research, in understanding how you best use tools. Because certainly for many parts of the world, we actually know now what it is we need to do. We know we may not need a super new drug, we do, and certainly in environments, but we often we know what we need to do. The real question is how we do that. How do we achieve universal health care in resource-poor settings? How do we get those interventions to those populations that are at greatest risk, or who are least able to access care? And I think some of the work we do there is as inspirational as the kind of sexier, here's a new drug or new vaccine. So it really is across the board for me.
And outside of the research that you're focused on, what are your plans to develop the school?
So I think we absolutely have to think about the next phase of engagement with the places that we work, the new partnerships that we need to develop. I touched on it earlier in the AGM, but the world is changing. We are seeing many countries now putting their own funding into research. We're absolutely seeing an explosion of bright, young, talented scientists in Africa and have been in Asia for some time. And we need to think how we best engage with them, how we can fulfill demands as an organization of those countries, of those ministries, and how we support those young scientists as they really do step up to become internationally recognized scientists. So it's dialogue, I think, for me with those endemic countries, places where we've worked for a long time. What is it that they see us having a role as? Because we have to make sure that we remain relevant in what is a very changing world.
And how about locally? How do you see the position of LSTM locally over the next, say, 5 to 10 years?
So I would like to see the strength of infection in Liverpool growing substantially, and I think we're on the right path to do that. That, of course, brings in, and we will be expanding, LSTM will expand in terms of its staff, and certainly in terms of the estate plans that we have. That will hopefully create new jobs. It will certainly create an environment that will all play into this idea of Liverpool being the place for the life scientists and the place in particular for infection. And I think that's the engagement that's going to drive things forward within the city. I think the city gains from having a place like LSTM. And some of our early research suggested that after the football clubs and the Beatles, LSTM, certainly in Africa, was the brand that was third best recognized. And that's really important to the city, and encouraging that and continuing with that, I think, is something that will be something we'll continue to do a great deal of.
So that's great news for the city and what you're going to do for the city. What do you see the city being able to do for LSTM over the next 5 to 10 years?
So I touched on it slightly, but I think already the support for the kind of work that we do is really important. And I'm not sure how many people have seen the developments in Paddington, but they are absolutely spectacular. The funding that the city put behind the new Royal College of Physicians in the north, I think, is a really important message to the country that this is an area that Liverpool's interested in. So for me, it's continuing that story of Liverpool being the place to do infection research, and that's, for me, I think, is the most important thing.
Thank you, David. So what I'd like to do is open the floor up for questions. For David, anything that we've touched on already that you'd like more information about, or anything else, really? Do we have any questions for David? There are roving microphones.
Thank you. You mentioned staff expansion and expansion of the estate. Sorry, I'm over here.
Right, sorry.
You mentioned staff expansion of the estate. Could you be sort of more descriptive, say what the school's going to look like in 5-10 years' time? What's your sort of vision for the next 5-10 years?
So I wish I could give an easy answer to that, because we're absolutely in the middle of deciding that. There's no doubt that we have got certainly access to land that we can build on. And again, it was touched on earlier in the AGM, the teaching expansion is something that we're thinking about very seriously, and the current teaching space we have is really not fit for purpose, certainly not if we expand the numbers, and also given the increasing expectations of the quality of education space that students want. So I think I see us not putting up a 100 and 120 million pound building in 5 years, but putting up a series of smaller buildings that will actually go alongside the gradual expansion of our activities over the next 10 years. And the first one of those is likely to be education in the UK. We have also very ambitious plans to expand our capital investment overseas, particularly in Malawi, where we have 600 people in a research centre at the moment, and aim to expand that. And certainly we'll look at other opportunities as they come up, either as teaching hubs or as part of this expansion of partnerships that I've talked about in terms of research.
Thank you.
David, you said some quite positive things about Liverpool and life sciences, knowledge, etc., etc. Do you still find, in the light of what you said earlier on at the AGM about the need to recruit the next generation of professors and leaders within the school, that the perception of Liverpool is still a fairly strong negative in terms of trying to recruit good people?
The simple answer is yes. I think there's no doubt about that. there's 25 or 30% of the population who live in the southeast who would never dream of literally going past north of Watford Gap. I think that's generally true. There are people who cannot even dream of going outside London. And so I think we are immediately accessing a smaller pool of people generally. But I do think, I think a really good example of this, we had the European meeting on tropical medicine very recently here. The number of people from London that came up to me and said, I had no idea how great a place this was astonishing. And we said earlier, Lstm is maybe one of those kind of hidden secrets. I think Liverpool is to a certain extent. If you can get people here, if you can get them to see the opportunities both professionally and also in terms of the kind of where you can live, the delights of being close to North Wales, to the Lake District, etc., then I think you can persuade them. As an organisation, Lstm needs to get much better at that. I don't think we've been clever enough in really pushing that message. And Sam Aries, our HR director, are looking at that. So I think it's a two-way thing. There was a group of people who never access, but there's a group of people, if you can get them up here, then they will absolutely love it as a place to be. There's no doubt there is still a negative connotations about Liverpool that we will take, I suspect, another 20 years to get rid of.
Thank you.
Do you think if you were to establish a Premiership rugby team in Liverpool, that you might improve your recruitment rate?
Well, I'd be absolutely delighted if we should do that. And if there are very rich people in the room who would like to do that, and you do need to be rich to run a Premiership rugby team, as Saracens have told us recently, then I'd be very, very supportive of that initiative.
Sorry, you've just talked about the next generation of leaders and professors and so on. One of the issues in the Liverpool City region is about raising the aspirations of young people, some of whom would never make it to be a professor, but would have a valuable role within a scientific environment, if I can put it that way. I mean, what sort of engagement do you have with schools, and would you see that as something that you could develop in the future?
So I think there's two bits of that, because I think your first point is really important. We kind of sometimes think about careers in research and science as the only output of that is if you're a professor. And if you don't become a professor, in some way you've failed. And that's absolutely not true. It's critical that we develop actually a society that's more science literate, because the levels of science literacy are really quite scarily low. So I think that the first thing to say, it is really important we get lots of people into science, and if they don't become a professor, but they go off and work in another environment, that's absolutely fine, and that's a contribution to society in Liverpool that we should be undertaking. Your particular point about schools, I don't think we have been as good as we should do. We've got a very good public engagement process, but I was talking only the other week with Steve Ward, who's Deputy Director, about how we need to be thinking about engaging with certain schools, and particularly those schools in the least advantaged areas, and how we can help use our expertise to attract young kids into science. There is currently a working group with Lstm looking at the way that we engage with the city, something I've instigated in the last few months. But that will be high on the list, because I think generally, not just for Liverpool, but for the UK, it's really important that we get the brightest kids into science, and currently, I'm sure we're losing a huge proportion of those. The drinks are calling.
Hi. I'm just wondering, do you feel that there's a need to increase representation and diversity in the leadership of the school, particularly surrounding women and BME groups?
So I think that there's absolutely no doubt at all that within Lstm, we have issues with gender representation at the high level. We have a gender pay gap that at the moment is not acceptable. Like many organisations, that's no excuse. And so I think we are facing the same challenges as many universities, many organisations about how we do that, and how we do that rapidly. I think that is a challenge. So I absolutely accept there's a problem. In terms of our And I think, and you rightly mentioned diversity generally, not just gender diversity, but I think ethnic diversity is something that we are looking, but only really just starting to look at now. It's been, I think, in some ways not been thought about enough. Yeah. Again, not just with us, with most universities. So the answer is yes, we have an issue. It's something that we are working with. We're working with people at all levels of LSTM to think how we do that. But it will be a slow process. It will be a frustratingly slow process, I think, because I don't think it's something you can change overnight.
Any more questions? Any more for any more? Okay then, thank you very much for engaging. And could you please join me in thanking David for sharing his time with us and sharing his expertise and knowledge with us. David, thank you very much. So I believe there's now some networking out in the hall, so please join us for that before a lecture in about an hour and 20 minutes time back in here. Thank you very much. Well done.
Yeah. Who is the best? So good evening again. And now we come to the highlight of the day. LSTM is very fortunate. There are very few endowed Leverhulme lectures, and I think David Molyneux started this back in 1997 with Viscount Leverhulme. So we're very fortunate to have these lecture series, and it's one of the most prestigious events in LSTM's calendar. And I'm delighted to ask Paul, who's known David for 40 years, to introduce our speaker tonight.
Thank you so much for that introduction. And I'm delighted to be able to introduce David. David Nabarro, medical doctor, international civil servant and diplomat, special advisor to the UN on the 2030 Agenda for Sustainable Development and Climate Change. To date, a stellar, extraordinary career, but he's still advancing the agenda. And of course, one could argue that David's career started as senior lecturer at the Liverpool School of Tropical Medicine, and he was one of the only staff member that had his basement a permanent dancing area to entertain master's students and at his house. And it was the only master's program at the time, and probably still, that had the race relations officer for Liverpool talking to master's students about race and inclusion in Liverpool. He moved from Liverpool to Diffid, where he ODA at the time as Chief of Health and Population, and tripled the health aid budget with Claire Short. He moved to WHO, set up and ran rollback malaria before Gates had even moved into the party. And then he did a lot of work with Brundtland, working in Baghdad and Iraq, as well as being executive director of the WHO at the time. And there's only one more sentence about your career. I was told not to talk too much about. But he was a coordinator to tackle avian flu, head of the UN response to cholera in Haiti, special envoy for Ebola, and latterly special advisor on sustainable development and climate change. And a busy person indeed. But David is a modest person who works by leading from behind and is a true diplomat. And this description of his career misses some of the most important qualities and impact of David in his support and development of others. I know, because he helped me. As a junior doctor in my 20s, I arranged to meet David at the London School of Hygiene when he was just back from Nepal from his master's. And he asked me what I wanted to know. I said, I want to go overseas to work, but first I want to complete my MRCGP, the higher degree in medicine. He said, don't do the MRCP. It will damage your brain. It will stop you thinking. Get jobs in busy district general hospitals. Learn skills, then you may be of some use. And then get out there. And so I changed my career, and I moved to Stoke-on-Trent, and really things, I took his advice, and it was incredibly helpful. And you know, in the years that followed, David really helped me with advice, support, affirmation, and challenging me. So he helped me find my way in those early years. And he does that with many people. I was on a minibus recently this year with 15 other people going to an immersion in living health systems, which David's going to talk about, for sustainable development, run by Florence and David. And around me on this bus were some really quite influential people that had done many interesting things, but the one thing they had in common was a personal story about how David had helped them and steered them on the way. So I'm delighted to be able to welcome you.
Thank you, Paul. Actually, the joy with Paul was really meeting with him in Papua New Guinea and working with you then and being able to work with you since, and watching how you adapted your brain to what people need And as I watched you developing this program on systematic reviews and coming up with some of the really excellent material that's for people, I'm proud of you. And so thanks for these introductory words. Now, the title that I've chosen for tonight, Engaging in Complex Issues to Secure the Future, might appear a bit obscure, but I hope that during the next 20 minutes or so, you'll find that it makes sense. And it's a lecture that I haven't given before. It's new stuff. And if at any time you feel this guy's got lost, just shout out, okay? And catch my eye and shout out, because I'm very happy to stop and reposition myself, except if all the lights go out, I can't see you, but I'll adjust. And because it matters, because the work that I want to talk about tonight is really about picking up on some of the things that David Dalou talked about earlier, related to how we tune in to the future and do it together. So what's coming? There's 8 headings, and I thought I'd give you the headings now and then take you through them. So this is the framing part, and there'll be a bit more of that. And then I want to share with you my own story about my journey, but particularly concentrating on the last 13 years, 14 years. And then I want to introduce you to the Sustainable Development Agenda and explain to you why it's my compass and what it means for me. Then I'm going to go into what some people refer to as Goal 2, which is the Sustainable Development Goal about zero hunger, and to talk about the new narratives that are developing on food. That's an example, because then using that example, I want to focus on the area of work that I'm most involved in, which is helping people to connect, helping them to get involved in dialogue, to discover what each other thinks and why, and then through dialogue to find that they actually have more in common than they thought. And so then there is some alignment, and then when there is alignment, the possibility of real shifts in the systems with which we're working. And that's going to be the centerpiece of my conversation. And then I want to lift out of that and say, what have we learned from some of these experiences about systems leadership, and particularly living systems leadership, as ways to navigate complexity, and then how can we take that in order to try to secure the future. And I'll explain very soon what I mean by that. And then the end is just going to be a bit of personal reflections. And I invite you just to be thinking, what do the initials LIL stand for? I'll tell you at the end. So here's the framing. For me, ever since I started working in public health, there were 4 words that really mattered to me. One was opportunity. Why can't everybody in the world have the same sort of opportunities as everybody else? Why do we have to create a world where opportunities are skewed? And then leading on from that, access. Why do some people, because of where they're born, have the capacity to access really amazing healthcare or amazing education, or even amazing employment, whereas others just have no chance? And what can we do as a community to encourage equity, and then to build into that equity the notion that our finite planet needs regeneration in everything we do? So those are my four main words that I'm going to try to build around. And I'm going to refer to my work in public health, which Paul just described, the work we're doing on food systems, And then I'm going to, if we get a chance, perhaps at question time, talk a bit about climate. Because for me, climate is the ultimate defining issue of now. And it's changing super fast. And it requires attention from world leaders now. And so that's why I've been working a lot with the Secretary General of the UN on climate. What I'm talking about applies to everyone, all ages, all groups, all sectors. In fact, I actually want to try to erode as far as possible the divisions that exist because of generation, the divisions that exist because of ethnicity or class, and the divisions that exist between sectors. Because I'm going to try to make the point to you that this securing the future requires us to reverse that tendency for separation and fragmentation, and to learn that working together in a very constructive way is the only way to work when it comes to securing the future. And so here's the challenge. When David was talking just now in his interview, which I loved, it was a pity it was a bit short, but in a way the brevity made it more poignant. One of the things he said is our world is changing, and we have to make sure that we're relevant for that change. So I want to pick up on that challenge, and so I changed this slide after I heard you talk. And I'm going to say, can we actually organize ourselves so that we are able to influence the direction of change rather than being passive recipients of change? And can we make it possible to be the generation that influences change for the good of people everywhere, rather than for the good of a very small number of people who have a lot of assets and power? But most importantly, can we actually work for future generations rather than for the current generation? For those of you who've got children, I'm thinking of your children's children. For those of you who've not got children or are not in that department at the moment, I'm thinking of the children who might come. Because learning to work for the generations to come might be the most important attribute that we have to learn as leaders of the future. Not for now, but for the ones to come. Just think about it. Working for people who are going to be of your age in 50 years' time. I'll come back to it, but that's the structure. So a little bit about the journey. Now, I discovered when I came here this afternoon that there's a little issue with these screens, that they're small. And I hate to do this, but don't feel that you've got to screw your eyes up to read the words. I'll take you through it. My usual instruction to people is never, ever have slides where the writing is too small to read, and I'm breaking that instruction. But that's the way it is. I was here between 1985 and 1989. Some of the people who I work with are in this room, and that's just a source of huge joy. I came here because the following thing happened. I was working in Nepal, and I was some way out of Kathmandu, and it was about 1981. And I heard that this amazing guy, who was really getting a fabulous reputation, called Kenneth Newell, was about to come to Delhi. And so I organized to come to Delhi, and then I got up at about 3 in the morning and went to the airport. And I stood there with a piece of paper saying, Professor Newell. And this guy walks out and, who are you? He had very big, bushy eyebrows, this guy, Kenneth Newell. Was really quite stern, but he smiled the most gorgeous, warm smile when he met me. And he said, okay, we'll talk. And he said, as we got in a little taxi going from Delhi Airport to Claridge's hotel, he said, actually, yeah, I want 2 hours with you because I want to find out the shape of your head. And that was this guy. He taught me 2 things. He taught
when you meet people, spend enough time with them, be curious about them, find out how they really see the world. And he taught me that really life is about systems. Nothing is ever linear. So it actually took a bit of time for us to work out how we would interact with each other, but shortly afterwards, it was a bit later actually, I was coming here to Liverpool, to the School of Tropical Medicine, and I was here between 85 and 89. And I think that my time here probably really set the foundations of an inquisitive, connecting mind that could never be stilled. And that was because the energy inside the Liverpool School of Tropical Medicine is quite unlike energy in any other educational institution I've ever been in. It just hums with the collective positive energy of everybody, whether you're on master's courses or diploma students or in the staff rooms. And so I want to start by saying I am really grateful for this institution, for the university, for people like Professor John Ashton, who I met then and who's here tonight, for showing me that public health is not a technical discipline, it's a political discipline. And you can't do public health unless you're comfortable with engaging in politics, because it's about power. It's about who has power, who can use power to change their lives, or who doesn't have power and who is excluded and marginalized. I pay credit to David Molyneux. I don't know whether he's here. He was a fabulous leader and taught me so much about global health. Tim Martineau, who's sitting in the back, with whom I worked in Nepal and who came here to work in Ken Newell's department. And so there are many, many others that I want to refer to, but for me, that time here at the Liverpool School of Tropical Medicine opened my eyes to possibilities. So then I went between 1989 and 2013 to work in various institutions, to work for what used to be called the Overseas Development Administration, so I was in the Foreign Office, to work for the Department for International Development, and Paul referred to that. And there we were able to take health and link it to other specialisms to create a directorate for human development. And that was the beginning of what I was trying to do, to make certain that health was connected to all the other sectors that matter. And then I went on to the World Health Organization, and my tutor there was Gro Harlem Brundtland, who in the same way taught me as a political leader, being a doctor is fine, being a public health doctor is fine, but if you want to make a difference, start to work with the politicians. That's where the real progress happens. And after that, I did shift a bit, and I went to work with Kofi Annan in New York, taking public health into UN Secretariat. They hadn't done it before, and this was because the challenges of avian influenza and pandemics were beginning to really disturb a lot of governments. And so Kofi said to the person running WHO at the time, could you send over somebody to help me? And I was the one who was sent. And so we started to build a group inside the UN that was putting health inside the political envelope of the Security Council and the General Assembly. And then after working on pandemics, I began to have a reputation as somebody who could coordinate, who could bring different groups together. And I didn't realize at the time, but actually people will hunt you out and pull you in if you can coordinate people who normally are fighting and snarling at each other, and if you can actually get them to work together on an issue that really matters. And this was 2008 when food prices were rising. And then it was Ban Ki-moon, Korean, who was the Secretary General, and he said, I need somebody who can help us to find a way to position not just the UN, but actually the world's leaders in a place where they can take food seriously, because food was not in a good space. We had huge rises in rice prices because of manipulation of the market, huge rises in wheat prices because of climatic causes. And our job was to try to find a way to bring the whole of the UN and the World Bank and the OECD and a variety of other groups into a place where they could work properly on food. But together with colleagues, my job was to say, yeah, we can do that, but we do it through working with communities and countries, through listening to their realities, rather than simply setting global rules. So we did that on food. And then in 2010, the area needed attention was nutrition. So we had to do some work on that. And then it became a bit wider, and my responsibility was for developing the Sustainable Development Goals, and then trying to make sure that the Paris Climate Agreement got properly signed and put in place so that we could start to work on climate. I agree, things are not good in all those areas. We've got some that are going wrong. But I want to tell you that that ability to bring different organizations together is one that seems to me to have been quite useful. And I'm going to go into the food story in a bit more detail and use that as my example, and then out of the food story, take you with me on the new work that we're doing to actually help people to learn the skills that we were practicing, because we couldn't find any university or institution that was teaching them. Now, moving to 2012, some of you will know that between 2000 and 2015, there was a huge global effort to develop goals that all different development agencies could pursue in a systematic way in order to make a real difference to the well-being of people everywhere. And this led in 2000 to something called the Millennium Development Goals. There were 8 of them: maternal health, child health, primary education, water and sanitation. There was one thing that was particularly important about these. They were goals for the world's poorest nations and the poorest people. And they were incredibly effective because they harnessed the collective energy of all the development agencies towards a number of clear objectives that had been endorsed by world leaders in 2000. In 2012, I was in Rio de Janeiro for something called the Rio +20 conference, together with Ban Ki-moon, and what we were looking at was, what did the world want to put in place for development after 2015? So remember, we had 2012. We had people like the British government who were saying the Millennium Development Goals were great, we just need to continue that way of working. But delegates from Brazil, from Colombia, from Indonesia, from India, were saying, no, actually we don't want the future of the world to be built around goals that are just about what happens in poor countries. Because actually the rich countries have got to shift even more than the poor countries. So let's have goals that apply to the world. And let's have goals that put the interests of people at the center. Let's have goals that recognize the interconnection of everything that goes on in people's lives. People do not divide their lives up into health, education, human rights. Everything is joined up. And so that led to 3 years of really hard work to develop this thing called the 2030 Agenda for Sustainable Development. 8 million people around the world were asked their opinions. There were 60 meetings in different countries to devise this new agenda. And when the agenda started to appear, thanks to amazing mediation by a Kenyan and an Irish pair of ambassadors, people got mad. Why? Because they came out with this agenda that had these principles about people-centeredness, universality, interconnectedness, integration, and partnering. And that was completely the opposite of where we were with the Millennium Development Goals, especially the universality. And then they got mad for one other reason, that there were 17 goals. And the communications people, Diedrich, where are you? Communications people said, 17? How can you market 17 goals? So we got a guy called Jacob Trollback to develop some nice icons and colors. And we said, well, let's at least make it a palette that people can believe. And then he developed this beautiful wheel that's become the trademark of the Sustainable Development Goals. But actually, when you look at this list of goals and when you read the document, the 2030 Agenda for Sustainable Development, these are amazing. And actually, there are 169 targets to go with these goals. And so what is this? It's actually the plan for the future of our world and her people. And it's the only plan there is. And given that we've only got one world, I think we have to take it seriously. So this is what I've been working on, both in the formation, and it's become my compass for life. It doesn't mean that I'm religious about it, it just means that I recognize that you can't just focus on the human issues that are in goals 1 to 6 without thinking about the economic and societal issues that are in goals 7 to 11. And then the planetary issues that are goals 12 to 15. And then the absolute need to be able to create systems in society for resolving conflict peacefully, goal 16. And none of this can be achieved without partnerships. Yes, there are things missing. There's not much in there about the internet. And that's always been a worry for people. But this is an amazing construction, and it was negotiated, as I say, by representatives of countries, endorsed by every world leader, and I think it's worth holding on to. So this is my compass. I expect it's compass for some of you. So then we're in 2015, and this agenda has been produced. And the Secretary General of the UN, Ban Ki-moon, says, quite thoughtfully, David, I think there's a problem, and that is that when it comes to goal 2, we still haven't really worked out what the right design for food systems for the future is. And he said, if you actually look at food, that seems to be an issue that is relevant for all the goals. Could you pull together a group of leading actors from businesses, civil society, government, and scientific institutions simply to answer the question, what do we do about food when it comes to planning for 2030 and beyond? So, to cut a long story short, this group spent a couple of years in meetings working away and realized that there's no simple single pathway to sorting out what's done with food. And that's because if we look at food and its purpose, it seems to go 4 ways. First of all, you want to be sure that food enables everybody to be well-nourished and healthy. Second, you want to be sure that producing food doesn't destroy ecosystems, doesn't reduce the pollinators, doesn't empty aquifers, doesn't damage any aspects of the environment by fertilizer runoff. You want to be sure that food production actually enables the 500 million smallholder farmers in the world to earn a decent living and doesn't lead to farmer suicides,
farmers selling up their property and migrating to cities, or farmers just giving up. And you want to make sure that the food production system isn't contributing to climate change. At the moment, it looks as though food and land use changes associated with food contribute around 30% of greenhouse gases. So actually, food is difficult. And actually, food has to be mended in a way that deals with all those areas and more. And there are many choices and trade-offs and a lot of people involved. And every food system has very much a local dimension. It's not a global issue. There are multiple food systems and they are local. So I basically decided, under the instructions from the Secretary-General, that we would find ways to try to sort out what's happening in food so that it could work better. Do you know that current economic analyses suggest that the total value of the world's food systems in asset terms is about $10 trillion a year? Current economic analyses suggest that the damage caused by food systems to human health, to the environment, to livelihoods and to climate has a minimal total cost for society of $12 trillion a year. There is actually something wrong with food systems and it needs attention. So, how do you deal with a problem when it involves hundreds of thousands of different organizations, when it affects the livelihoods of probably households that probably contain about 2.5 billion people, when it is leading to apparently about a third of the deaths in the world today? How do you deal with a problem of that magnitude when there's no single person or organization in charge? Well, what we decided, frankly, as a result of many, many people coming together, is that when you've got an issue where there is a lot of contest and a lot of dispute, the most important thing is to talk about it. And so a program called the Food Systems Dialogues has been developed by a group of organizations, NGOs, business organizations, and international partnerships. And these are designed to connect different actors together in a structured way, facilitated, safe spaces where people can say what they like without being caught, no tweeting during the moment, and having a red thread of emerging priorities through the discussions. So there have been 22 food systems dialogues around the world involving more than 1,300 practitioners, from CEOs of companies and government leaders to farmers and fishers. They've taken place on 6 continents in the last 15 months, in 18 countries, and they've come out with 10 major themes that have been collated together and are now being fed through to plans for a summit on the future of food, which is being convened by the UN Secretary-General in September 2021. There are 4 big themes that have come out through this work. And this is the only piece of substantive comment that I'm sharing with you as an example. And I could have chosen examples from the climate space or the health space, but I wanted to show you this one. There are 4 big themes that have come out. One wants to link together wants to make sure that all efforts in the food arena have human nutrition and human health as a primary goal, i.e., stop producing and certainly stop subsidizing food that is contributing to the non-communicable disease epidemic, contributing to these 1/3 of deaths that are diet-related. put nutrition into food. It's not there. I'll tell you that straight. It's not there. So bringing together health people with agriculture people, with food retail people, and making certain that they are joined up is task one. Task two, if you're going to bring about changes in food, make sure that the people who are involved in the food system are at the centre of the discussion. Don't lock the farmers out. Don't ignore the fishers. Don't neglect the challenges faced by busy mothers who want to be able to discuss how they're going to feed their children. Make sure that everybody is there and able to be involved. It's so obvious when you're inside this space. And yet I go to meeting after meeting on food where no farmers are to be found, no fishers are to be found, and there's very little listening to women with small children. There's very little attention to the needs of very poor people who can barely afford decent diet in their homes. Third thing, people working in food can have a huge impact on the environment, farmers especially. But they're not going to change if they get told by governments, stop using Roundup, don't use fertilizer, stop using these kinds of seeds, because urban consumers are instructing their representatives to issue those kinds of edicts. They're going to say, hang on, we've been using these fertilizers for many years, and actually they're important for our production systems. Or, hang on, if we can't use weed killers and pesticides, we're in real trouble. It's really important that if we're trying to work with farmers on environmental and planetary change, that they are part of the discussion and not treated as objects. Why are French farmers protesting yesterday and today and complaining about their president? Why are Dutch farmers out on the streets and ramming their tractors into local authority houses? Why are British farmers threatening, if the Brexit exit terms are bad, that they will go on, they will do blockades because of serious problems in the lamb and dairy sectors? Because they're not being included in the discussion. That's the origin of the Gilets jaunes movement in France. And then fourthly, if we really want to see food systems change, we must talk to the investment houses like BlackRock that put hundreds of millions of dollars a year into food. Why are they putting money into food that is actually killing people? So this has come out of these discussions. We go off to have a meeting on Monday in New York with a lot of investment houses actually starting to ask the question, what do they want to be investing in? I reckon in 5 years' time, as a result of this process of dialogue and the red threads that are emerging, that we will see shifts occurring quite dramatically in how food systems work. You can see the green shoots already. So that's just one small example of trying to find a way to create momentum when there's no obvious leader and an awful lot of groups involved, done through facilitated dialogue. It's been super hard work, and it's still going on, but I think that it's starting to bear fruit. So I thought, together with a lot of colleagues, this is not me on my own, can we create just a way of describing this approach to navigating complexity, to connecting people so they try to find common cause, and doing it in a way that is politically informed. Doesn't mean one has to be a party politician. Certainly the UK food dialogues have been absolutely non-political in the party political sense, but immensely political in whether the power of the people to influence is there. Can we take this further? what have we been doing? So if you could start with the bubble that's at about 10 o'clock, I think, connecting intensively with curiosity. It's back to where I started when I was at Liverpool being taught by Professor Newell. Get into people's heads. Find out what they think and why. There's always a reason for it. Meet them there. That is the starting point. And then, because each person who you meet and talk to is part of a system or a series of systems, sense their systems through listening to them in their words and consulting them. This is so important. I mean, David was talking about it in his interview, but Bertie was also talking about it in the session earlier this afternoon, those of you who were there on TB in Malawi. You could feel that Bertie and his team have been really feeling into what's going on in Malawian communities and understanding how life looks from the point of view of the people of Blantyre and elsewhere. It's a skill, but everyone can do it. And a lot of people don't do it because they've not been encouraged to do it. And then there's the next step, which is when you actually start to bring people together who feel pretty much the same. And so you assemble networks with a common purpose. But there are three key words. One, identity, what we stand for. We're doing this work because we stand for the public good. We're doing this work because we want people everywhere to have the same opportunity. We don't have to walk around with a badge. Don't have to. We don't have to be intolerant of each other if they don't share our beliefs. We just find a supplementary identity on top of the identity we already have as a student at LSHTM or as chair of the Board of Governors or whatever else you are. I mean, I'm trying not to be silly and make mistakes. We just need the supplementary identity that defines what we're working for. And then in our networks, we actually pay attention to each other and to building relationships so that we can work together. And if we can focus on the identity and the relationships, then we can start to share not just information, but we can share our feelings and our anxieties, because that's what makes teams really work. Because out of those three words, identity, relationships, and sharing, comes trust. And when there is trust, we can move mountains. Of course, there will be times when we make mistakes and we break trust, but we're human and we can recover. Because then we can get into dialogues, we can explore priorities, we can find trade-offs in decision-making, and we can start to assemble the case for doing things differently. We can co-create narratives. Narratives are so important that bind us together and find the pathways that frame the journey that we're on. And most importantly, as we're trying to build collectives of action, we do something absolutely vital. We cradle the process, which means that we provide safe containers within which people can find ways to work better together. There's a lot of that goes on Merseyside. It's one of the things that this city is famous for and this community is famous for. There's a lot of it happening in many other places, but actually if we don't make the effort to create more and more cradles, people work in isolation, they fragment, they just spend their whole time saying, I don't agree with her or him for this or that reason, that we create the reverse of what we want. So by creating cradles, we can build collective efforts. And then the coalitions start to build and the movements are there. All of you will find examples of this way of working in your lives. All of you will know people who are really good at identity, relationships, and sharing, who are brilliant at cradling different actors together so that they will work differently. But unfortunately, this is not what is taught in institutions. It's not what we get marks for if we're in our annual appraisals, and it's often not what helps us
to get the jobs that we're after, because these are sometimes referred to as soft skills, and they're seen as voluntary. But I'm making the point to you tonight, and it's my main message, that the soft skills of interpersonal working, trust building, are actually more important than the hard skills of whether you can do a good experiment in the laboratory or whether you can run a good field trial. Actually, you can't run a good field trial without these skills. We all know it, but nobody actually picks it out and names it. So we have, and we call it living systems leadership. And a guy called John Atkinson, who we work with, who's a disciple of a guy called Myron Rogers, has been our creative energy behind this. And Paul came along to one of the sessions, so that's why he referred to it. But this exists. And then we can start to say, well, we're complexity navigators. Sorry, am I going on too long, David? Okay, thank you, just checking. We can see ourselves as complexity navigators because learning to work in this way helps us to be comfortable with complexity, so that instead of saying problems are too complex for us to handle, so we'll go for the low-hanging fruit, we turn it round the other way. And we say the important problems are horrendously complex, but we're willing to embrace them because we have a methodology that will help us do it. We welcome different understandings. We value networks. We appreciate the potential of coalitions. We anticipate that new ways of doing things will emerge if we get this right. And to do this, there are three real attributes that we need. One, we're after equity. We're after fairness. We want the planet to be regenerated. We do not want 2 generations' time people to be saying, like Greta Thunberg says, you've stolen our future. We don't want that. We don't want to be stealing the future of coming generations. But to get towards the point where we're working for that future and securing it, we have to be into the political sphere. All this work is totally political, as I said at the beginning. Secondly, we will get despised for what we're trying to do, because this way of working challenges vested interests. It's just really unfortunate, but it's true. There are too many people who profit from the current skewed power relations, and if we're trying to get greater equity, we're going to face adversity. And then thirdly, we never know whether we're doing any good. This is my big nightmare, even now. Am I doing any good? Don't know. Wake up in the night. Are we actually moving the needle? Don't know. Am I actually making a difference? Don't know, because this kind of work is collective, and often you don't have nice, neat milestones on the journey when you're trying to make a big difference. So there are 5 things, finishing now, that I would like you to hold in your minds when you're thinking about this way of work. And this is something that I think is important. Number 1, hold competing perspectives in your mind simultaneously. Don't get upset if you feel that there are 3 or 4 or 5 or 6 different answers to an issue. Hold them there. Don't get troubled. Secondly, look at the big systems as well as the little pieces. It's not enough just to deal with the little pieces. You've got to look at the big. Thirdly, feel the pace and rhythm of the systems in which you're working. Be a disc jockey. Try to work out what the tune to play to get everybody dancing in the next 15 minutes might be. If you can get into that way of working, you don't end up with that terrible problem of interacting with people and finding that they're just, don't understand you. Fourthly, every system behaves differently in a different environment. I mean, you all know that. You all know it, those of you who work in health, you know that if you go to one health centre
and go with the same program, and you go to another health center with the same program, it will be different in the different environments. And these vertical programs where they try to standardize everything, again, as David said earlier, are a bit of a disaster because they actually behave as though the environment doesn't matter, but it does. And then fifth, don't meet people where you think they should be, meet people where they really are. That was the beauty of the discussion we had about tuberculosis earlier today, and which Bertie set up so well. The whole focus was on actually the person who is ill is the center of everything. Meet her or him there. So my own journey ahead is partly influenced by big international meetings, climate meetings, biodiversity meetings, food meetings. But I thought when I was finishing, actually, that's not what I really believe. I think these big global meetings are important, get a lot of people coming together, and you feel as though you're shifting the needle. And certainly I am pleased that more and more leaders are saying there is a climate emergency or there is a planetary emergency. It was agreed by the European Parliament yesterday, I think, yesterday. And yes, the future has to be a decarbonized future, and it is so urgent, so urgent. The planet is heating at an accelerating rate. A paper appearing in Nature today says of the 14 serious planetary boundaries that we've got to look out for, 9 are already either crossed or nearly crossed, ice melts and the like. So this is so urgent, and we mustn't lose sight of that. But also, actually, we've got to bring nature back into our lives, nature back into agriculture, nature into urban planning, nature into infrastructure. The future is not simply pretending that living systems and nature are not part of the world we want. In fact, they are key to the future. But the way we do this is combining the local and global, combining all nations and all people. Forget that developed country language. It's not real. Every nation has bits that are poor and bits that are rich, people who are deprived and marginalized and people who are super wealthy and well off. Every nation. So that means working at community level, working at local government level, working with businesses. Do not shut the businesses out. Some business leaders have much more to offer for the future than an awful lot of government leaders. And do not believe that simply focusing on making yourself feel comfortable will solve anything, because this requires collective energy by all of us like never before. Not just in this room, but by hundreds of thousands of people next year, by millions of people the year after. It's the only way. It's the only way to make the Sustainable Development Agenda come to life. And that to do that, you have to connect beyond your comfort zone. Forget the Facebook group. Forget it. It's no good. It's an echo chamber. Get out and meet and work with people that you would not normally meet and work with. Whenever I go to meetings and there's networking, I say, talk to 10 people that you otherwise wouldn't talk to. Forget your shyness. Just do it. You will discover through connection opportunities that you didn't know existed. And you have to be multi-stakeholder and interdisciplinary. I want to try to erode these terrible barriers between academic disciplines. Certainly in my job at Imperial College, I'm trying to do that. And intergenerational. Thank goodness there are people here who I suspect are around a third of my age. Great. You should be the people who are telling us what you want for the future. Because it is people-centered. It is political. Take a political position. Make sure that when votes are cast, they're cast for actually people who look as though they're going to govern for the future rather than for the present. Govern for the 12-year-olds rather than the 72-year-olds. Be brutally honest. And most importantly, be stubbornly optimistic. LIL, I learned it in Liverpool. Thank you very much.
Brilliant, Dave.
Your ideas.
I mean, I'd like to thank David for a fantastic and incredibly thought-stimulating talk. We've got about 5 or 10 minutes for questions, so maybe just get lights up a little bit, and I think there are microphones roving around the room, because I'm sure many people are still trying to absorb that, but also have got questions about it.
Was it, just out of interest, was it recorded?
I think it has been, has it, Danielle? Is that right? All these been recorded? Yes. Yeah.
So we'll be able to see, I'll be able to check whether
it made sense.
Whether it made sense,
yeah. John, yeah.
Well,
it's just behind you.
To kick it off, David.
My former guru is still here.
Not at all. If you were starting again, what would you do differently?
John said if I was starting again, what would I do? I just have to say, Edith Piaf's song, Non, je regrette rien. I think that I have been so privileged to be in position after position where I've been able to learn and then apply, and learn and apply, and to have mentors like Kenneth Newell, who I mentioned, like John and others, who encourage me to connect and be courageous. So I would have done this. I mean, I'd like to have had the courage, John, to have been teaching systems leadership a bit earlier, because I think it's useful. But then at the same time, I had to do it and feel it. So yeah. But I mean, I'm not going to ask you now, but if we get a chance later, I'm going to ask you that question as well.
Over by Claire at the back, yeah. So
David,
yeah,
so nice to see you again.
Right.
When you used to come to WHO from DFID, I used to listen to you and I said, he's a health philosopher. And you are a philosopher. Right? And
but is philosophers practical or is philosophers just
very
theory?
practical, that's what I said.
Yeah.
And we came to know each other when you were working in WHO in Geneva, right? And it's so nice that you said that public health leaders must know the politics of health and political economy, right? Now tell me, what you're going to do, what will be your tactic? Because high fructose concentrated syrup coming from corn, from Iowa, and nobody wins a president without Iowa's vote, and it's everywhere, and this sugar-induced obesity epidemic, and NCD is coming out, right? Yeah. And then president is saying climate change is not his something he can do. How you're going to convince them?
Right. So people often say to me, aren't you thoroughly depressed that it looks likely that President Trump will win in 2020? And I say, well, he may. And yes, I'm disturbed when people who seem to be working in an absolute opposite direction to what I want are in leadership positions. But I've always believed that power is with the people and that the people will, in due course, be able to make shifts. So, what to do about food? Consumers. Consumers will make more and more choices. Secondly, producers. Farmers are not going to go on just producing stuff that they know is likely to have difficult markets in the future. We already see signs of that with the dairy industry really having to contract and pull back and probably going to be out of business. And I think, thirdly, governments are going to stop subsidizing sugar or subsidizing maize. We're seeing that from many emerging countries. Most countries are not listening to what's happening in America. They're looking at what's happening in their own borders. Indonesia is, Brazil is, India is more and more, China is, because these shifts are happening. So, I mean, I'm just looking and I'm saying the shifts are happening, and just because we see retrograde action in one large economy doesn't mean all is lost. I agree it makes life difficult, but that's why we're doing what we're doing. I mean, we wouldn't be doing it if it was easy. But we'll talk about it more afterwards, Munir. Munir, when in WHO, was always the guy who would ask the really tough questions when you were at staff meetings. So it's great that you haven't changed. Excellent.
Any your questions?
Ma'am.
Yeah. Just work. That's fine.
What do you think will be the next technical innovation that will help our future regarding public health, or more especially food security?
Right, the next technical innovation. Gosh, I mean, I just say straight away that for me, seeing the power of apps that enable people to, first of all, get diagnosis when they are perhaps a day away from a health centre are really wonderful. And I'm watching more and more examples of that, with people being able to photograph lesions and be able to send them and get an opinion. So I think the whole IT revolution affecting both health and food and agriculture is really important. But honestly, I actually think that more important than technical innovations, what's your name? Manon. Manon, more important than technical innovations are organizational innovations, way we work. So for me, the thing I want to see more and more is universities that actually advertise courses in leadership that are not structured according to separate disciplines. I want to see opportunities for young people to be actively involved in global decision-making, like the 700 that came to New York for the Youth Climate Summit on the 21st of September, where I was at. That's the kind of innovation I think really matters. They're not so much technical, they're more organizational, and the politics of organization. So partly what I'm doing here is, I'm not so much talking to David. I mean, he's a little bit hands tied because his thing's called the School of Tropical Medicine. But I do hope that there will be lots of discourse between the people working on health, in food, and in other aspects of human endeavor. So that was my answer to your question.
Bertie.
Bertie.
So, David, a really inspiring talk and much needed optimism. A couple of things struck me, though, that made me feel less optimistic. One of them was, you said we need to involve business, and I see yes. But I see a gap between the primary producer and the consumer. And increasingly, I'm concerned about this concept of commercial determinants of health. And if you think about how long it took for us to make the journey from smoking to non-smoking, in the same way, in the countries where I work now, I see the commercial determinants, the non-nutritious foods, they have a massive impact. And I worry whether you get any sense. My question is, in this big dialogue, have you managed to include business in a way that moves beyond that commercial imperative, which at the moment seems so destructive?
So Bertie has asked me the horrid question. I was hoping it wouldn't come. You see, here it is. In smoking, the tobacco industry was really bad and fought against the public health community, lobbying, governments. And have we got the same happening in food? Are the commercial food companies just ignoring all the nutritious information we've got about obesity, ignoring the information we've got about type 2 diabetes, and just insisting on going on pumping out their stuff? I don't think so, Bertie. They want to be around for another 100 years, whether it's Mars or Unilever or Nestle, and they know that they're not going to be able to get away with just simply promoting really damaging stuff to people. But the question is, what are the additional bits of pressure we can put on them while still talking to them so that they know they have to change? And that's where I think the work that's happened in the WHO through the nutrition group that's really identified malpractice by certain companies, calling it out has been really useful. That's where having citizens' action groups, including in Southern Africa, who are really taking on the large food companies, has really created an environment where they know they have to change. So it has to be working on multiple fronts. You've got to, in my view, you need the strong civil society pressure. And you need really powerful action from public health professionals. You need governments to be beginning to wake up to the reality that their hospitals are beginning to fill up with people with complications of diabetes, and they've got to do something about it. And then to find the food leaders who want to change. It won't be all of them. And the rule that I'm working on is that if in a community of 100, 20 of the main leaders are ready to change, that establishes a new norm. So I want you to keep an eye on me. And if you feel that I've gone soft and I'm cozying up to business too much on food, come and give me a good kicking. Because I think, and the kicking, the reason why I'm asking Bertie to do it is he was a week ago, I can't remember where you were a week ago. Malawi. He was a week ago in Blantyre, and you will see what's really happening. And sometimes we don't see it because we're sort of in comfortable boardrooms. So all of you need to be part of the global witness of where there is badness, and then you need to come to people like me who have the ear of CEOs and say, look, David, that company is still promoting baby breast milk substitutes in a really unacceptable way. Or this company is still pumping out highly sweetened and sugared fruit drinks or sodas, completely disregarding health, and put us on the spot. That's how we have to work. That's why I talk about this networking. We all have to be with each other on trying to make it happen. I hope that's, I know it's probably not totally satisfactory, but it's a bit of an answer.
I think we probably need to call this to a close now, but David will be around now for the drinks, and I'm sure people can talk to him now. So David, it's a real privilege to hear you talk.
Thank you.
Thank you very much.
I'm sorry I was a bit long-winded. So oh, it was gone now. The email address that was up there, please don't hesitate to write, okay?
I'm delighted to give you the Leverhulme Medal.
All right.
And thank you very much indeed.
This is it. Can I open it?
That's open it, yes.
I'm just going to tell you what it looks like. There it goes. Leverhulme, okay? Here it goes. Lever Brothers. Does anybody know what they did? Soap. And they are the people who founded this company, Unilever. Unilever is probably the most sustainable of the big multinational companies operating in food. They are cool. And so I'm super proud to receive this medal because I think it's also a bit of a testament to somebody who started early on actually with this global approach.
Thank you very much indeed.
Fun. Yeah.
And that concludes the formal proceedings, but there are drinks outside. So thank you very much for people for coming. I hope you've enjoyed the day and enjoy the drinks.